Thank you, team, for this beautiful recitation of Saraswati Vandana. Now I'd like to invite our organizing chairman, Professor Rajendra Prasad sir, to kindly give the welcome address.
Good afternoon. Professor Bipin, chief guest of this function, especially organized on World TB Day and the CME on tuberculosis. The rest of the persons sitting on the dais, my own, beneath, also Dr. Pupi is also my own. And then Dr. Suryakant and Dr. Ved, and I see many faculty from Department of Respiratory Medicine, many private practitioners, students, persons from press and media. This is being organized on the day of, on the eve of, rather I can say, World TB Day, which usually is being will be celebrated on 24th of March. When we first let me say, at least I am very happy today. Both the departments which originated from the department, they are sitting here, and most of the faculty are also sitting here. So I must say, as a fatherly figure, I am very happy that both the departments are here. And क्योंकि मैं हमसे हमेशा कहता हूँ, दुनिया में चीज़ें आती और जाती रहती हैं, लेकिन हमारे अपने रिलेशंस को हमेशा मेंटेन करके रखना चाहिए. So I must compliment Dr. Ved and Dr. Suryakant to be here. And we talk about tuberculosis. You know that tuberculosis is a very curable disease, I always say. But still, if you see the last year figure, around 5 lakh people have died with tuberculosis in this particular country, in India. Question comes in my mind, why? There is so much of political commitment, so much of new diagnostics have been there in last 7-8 years, I believe, since our beloved Prime Minister has declared that we have to eliminate TB from India by 2025. But still, so many people are dying. We have never drugs. You know, all the drugs you can imagine in tuberculosis is all available in the control program free of cost. Whatever newer studies, they come, and I'm happy that I'm part of many of the committees. The government of India adopt them as per our need and as per our requirement. I must inform you, 7 days back a study came when I used to talk that probably there is going to come as a universal treatment. The time has come now. Now a study about 7 days back came, and it says that drug-sensitive TB can be treated within 2 to 3 months with the newer drugs. What we used to treat in 6 months, before 2 years. So things are moving very fast. But it is very unfortunate, many people are dying. And only my assumption is that not all the patients of tuberculosis who are present in the society, they have not been detected early, and if detected, they are not put on treatment effectively. I know that. I said in my first sentence, it's 100% curable disease. I say like this. I say these words, although it is written in books also, I say these words by treating maybe lakhs and lakhs of patients of tuberculosis in last maybe 50 years. So what we have to do actually? One more word I would like to clear. When Modi ji has given term elimination, actually elimination means what? Initially, you know, this was revised national TB control program, especially press people are saying. Now program is known as TB elimination program. Means we are heading towards elimination. And what is the target of 2025? It is also very clearly defined. What we call it as end TB strategy. And what it says? It says that whatever incidence of tuberculosis was there in 2015, to be very precise, it was 256 per lakh. And it has to come down to nearly 44 per lakh by 2025, though the WHO and other agencies say by 2030. But our government has commitment. And the death, which was around in 2015, because these figures are taken at the level of 2015. In 2015, death rate was around 45 per lakh. And it has to come down by 2025 around 3 to 4 per lakh. That is what is the definition of a end TB strategy. That is the definition of TB Mukt Bharat. जो 2025 तक होना है जो बहुत, let me say, program was running very good. All commitments, all new diagnostic. You know, today we have around 25,000 microscopy center. We have 5,000 molecular diagnostic labs, which we have never dreamt. We have all sorts of treatment, I said, which government is providing free. And you know, our president and prime minister both had TB Mukt Bharat Abhiyan, in which what they say, everybody has to cooperate, everybody has to work on a mission mode so that these things can be met. Although we are going very fast, but unfortunately, 2 to 3 years of COVID has made all different. If I tell you today's figure, as I said, it was 256 in 2015 per lakh. Before COVID, it came down to, now we come to, because it has risen, so it is around, it has written little, apart 2 per lakh. The government of India is again working on it. They are not going to believe on the data of WHO. So there is a team has been set up. Even national prevalence survey has been done and results out. So they are probably, these figures are, because you know all the figures are estimated. It is not the real figures. So where we are, but one thing is certain, we are behind. And all we have to work with very passion, with mission mode, so that this dream, whatever our elders have seen, whatever our Prime Minister has seen, we may be able to fulfill it. May not be, I used to say, because we have already wasted about 2 years of time. So probably, if it will not happen by 2023, but one thing very positive, I think, at least we have commitment, we will reach somewhere near that. That would be also a very good job done to my understanding. I think with these few words, because whenever I talk about tuberculosis, I believe let me clear some of the doubts in the mind of, क्योंकि बहुत से पॉलिटिशियन पूछते हैं क्या साहब 2025 भारत से टीबी खत्म हो जाएगी? You must have understood what do you mean by भारत में टीबी खत्म हो जाएगी. उसका एक टारगेट है और उस टारगेट को लेके सारे लोग चल रहे हैं. With these few words, I'm happy that Ved most of the time organizing chairman. I don't know why, but still it is his love and it is his affectionate and as a chairman of this one-day CME and on the occasion of World TB Day, I welcome all sitting on the dais and then everybody sitting in front of me. Thank you very much.
Thank you, sir. Now I invite our guest of honor, Professor Suryakant sir, Professor of Respiratory Medicine, to deliver his message.
Most experienced, dynamic and visionary Vice Chancellor of King George Medical University, Lieutenant General Dr. Bipin Puri sir, our own teacher and very proactive Vice Chancellor, Dr. Vineet Sharma sir, and teacher of teachers, as everybody knows, a mentor of most of us, Dr. Rajendra Prasad, and our dynamic, vibrant student, organizing secretary of this today's function, Dr. Ved Prakash, Dr. Kushwaha, Dr. Darshan, Dr. Jyoti, and so many dear friends, Dr. Ashok Yadav, and friends from media, press and media. टीबी मुक्त भारत अभियान में जो गति मिली है वो मिली है 13 मार्च 2018 से. इसी दिन विज्ञान भवन दिल्ली में, सौभाग्य से मैं और डॉक्टर राम शाह दोनों मौजूद थे उस समय विज्ञान भवन दिल्ली में. उस कार्यक्रम में प्रधानमंत्री जी ने डायरेक्टर जनरल WHO के सामने घोषणा की थी कि भारत इंटरनेशनल टारगेट के 5 और 10 साल पहले, कुछ इंटरनेशनल टारगेट 2035 कह रहे थे कि टीबी मुक्त करेंगे, कुछ 2030. भारत के प्रधानमंत्री श्री नरेंद्र मोदी जी ने कहा कि नहीं, हम तो फास्ट फॉरवर्ड में चलने वाले हैं और हमने विजन रखा है एंड टीबी बाय 2025. दोस्तों, बहुत अच्छी चीजें चालू हुई, इतने नए प्रोग्राम आए जिनको अभी इस उद्घाटन में कहना मुश्किल है, लेकिन बहुत सी चीजें शुरू हुई. लेकिन थोड़ा सा ब्रेक लगा स्पीड में. मुझे तो लग रहा था ये कि बिना ब्रेक की गाड़ी है, लेकिन थोड़ा ब्रेक लगा. वो लगा जब कोविड आया. कोविड के दौरान आप सोचिए कि करीब 40% जो हमारी एफिकेसी थी, डायग्नोस्टिक हो चाहे ट्रीटमेंट हो चाहे और दूसरी चीज़ें हो, वो नीचे चली गई और इसलिए इतना बड़ा सेटबैक लगा. लेकिन फिर भी हम लोगों ने हिम्मत नहीं हारी है. और मैं खास तौर पर बता दूं कि किंग जॉर्ज मेडिकल यूनिवर्सिटी ने, जिसको कहते हैं ना, एकदम लंबी उछाल ली है अंडर द एबल लीडरशिप ऑफ आवर ऑनरेबल वाइस चांसलर. और सर का जब भी टीबी का हम कोई प्रपोजल रखते हैं पूरा समर्थन रहता है. तो इंटरनेशनल यूनियन अगेंस्ट ट्यूबरक्लोसिस एंड लंग डिजीज, मैं अंतर्राष्ट्रीय से बात करता हूं, इंटरनेशनल यूनियन अगेंस्ट ट्यूबरक्लोसिस एंड लंग डिजीज ने हमारे किंग जॉर्ज मेडिकल कॉलेज को पहले रैकी की और फिर बाकायदा विजिट की और 3 से 4 बार विजिट की. अल्टीमेटली हमें सिलेक्ट किया है इंटरनेशनल यूनियन अगेंस्ट टीबी एंड लंग डिजीज ने सेंटर ऑफ एक्सीलेंस फॉर ड्रग रेजिस्टेंस टीबी. ये बिल्कुल संभव नहीं हो पाता अगर हमारे माननीय कुलपति जी का हमको समर्थन और सहयोग ना मिल पाता. जब भी आए वो टीम, क्योंकि उसमें इंटरनेशनल यूनियन के लोग रहते थे, उसमें मिनिस्ट्री ऑफ हेल्थ के लोग रहते थे, 2 बार तो हेल्थ सेक्रेटरी ने विजिट की, साथ में डायरेक्टर जनरल ट्यूबरक्लोसिस हैं हमारे डॉक्टर राजेंद्र पी जोशी, वो तो पिछली बार बिना बताए हमको आ गए. हमें उन्होंने फ़ोन किया स्टेट टीबी ऑफिसर ने कि डायरेक्टर जनरल टीबी आए हुए हैं भारत सरकार, आप कहाँ हो? मैंने कहा मैं तो अभी देहरादून लैंड के आया हूँ, एनएमसी के इंस्पेक्शन में आया हूँ. तो और वो भी उस समय 5:30 बज रहा था. मैंने कहा इस समय तो 4 बजे कोई होगा नहीं. खैर डॉक्टर ज्योति मौजूद थी. सर हमारी इज्जत बचाई इन्होंने, ज्योति ने. मैंने कहा डॉक्टर ज्योति मौजूद हैं, आप उनको कराइए. अब जैसा वो दिखा पड़ा सर, और आपको विश्वास नहीं होगा, वो उन्होंने अननोन बन के कुछ टीबी के मरीजों के इंटरव्यू भी ले लिए और वो भी ले लिए. लेकिन सर बताता हूँ, KGMU का झंडा बिल्कुल नहीं झुका, KGMU का झंडा बिल्कुल ऊंचे बना रहा. और मैं बता दूं कि बहुत बढ़िया कमेंट देखे गए, वो लास्ट कमेंट जो देखे गए हैं और इतना एडमायर किया उन्होंने कि डॉक्टर साहब ये तो टीबी के मरीज आपकी तारीफ कर रहे हैं इतनी, और डॉक्टर ज्योति ने तो बहुत अच्छा हमें दिखाया। डॉक्टर ज्योति को अभी 2 साल हुए हैं असिस्टेंट प्रोफेसर, इनको बधाई हो, अभी 2 ही साल के हैं ये, लेकिन बहुत अच्छा इन्होंने उनके सामने प्रोजेक्ट किया आपने उसको। और सर प्रोजेक्ट कैसे किया जाता है ये तो सर हम लोग आपसे सीखते रहते हैं। इसके अलावा उत्तर प्रदेश में एक समस्या आ रही थी कि 25 करोड़ की जनता है, 75 जिले हैं, 18 डिविजन्स हैं, और सबके पास बहुत सारे टीबी के मरीज हैं। तो डिफिकल्ट टू टीबी केस अगर पूरे उत्तर प्रदेश में है तो कौन मार्गदर्शन दे। तो हम लोगों ने एक योजना शुरू की, और मैं बता दूं उसमें भी किंग जॉर्ज मेडिकल यूनिवर्सिटी ने लीडरशिप ली है। डॉक्टर अजय वर्मा उस काम को देख रहे हैं हमारे यहाँ से। और हमने शुरू किया डिफिकल्ट टू ट्रीट टीबी क्लिनिक। ये ऑनलाइन क्लिनिक होती है, वर्चुअल होती है, महीने में 2 बार होती है, और हमने शुरू की थी ये 30 जून 2021 को, और आज तक कर चुके हैं। और बेस्ट डिफिकल्ट टीबी क्लिनिक ऑफ एनी स्टेट इन द इंडिया, ये हमको अप्रिशिएशन मिल चुका है। हर स्टेट ने, लगभग हर स्टेट ने शुरू किया, लेकिन सबसे पहले हमने शुरू की, पायनियर शुरू की, और सबसे अच्छी क्लिनिक हम चला रहे हैं। ये भी हमारे सर के आशीर्वाद से हो रहा है। अगर आप में से किसी को भी मरीज जो है वो डिफिकल्ट ट्रीट टू टीबी क्लिनिक है, यहाँ डॉक्टर ज्योति और दर्शन बजाज दोनों हमारे नोडल ऑफिसर, और डॉक्टर एस सिंह कम्युनिटी सिंह से, तीनों हमारे टीबी के जो मेन नोडल ऑफिसर में बैठे हुए हैं। तो इनके नंबर ले सकते हैं आप, अपना जो फॉर्मेट है उस फॉर्मेट में दे सकते हैं, और हम लोग उसका समाधान निकालेंगे। तो किंग जॉर्ज मेडिकल यूनिवर्सिटी अब पूरे उत्तर प्रदेश के 67 मेडिकल कॉलेज को, 75 जिलों को, हर डिस्ट्रिक्ट टीबी सेंटर को हर लीडरशिप दे रहा है, और पूरे उत्तर प्रदेश के जितने फिजिशियन, चेस्ट फिजिशियन हैं जो टीबी की डायग्नोसिस और ट्रीटमेंट में इन्वॉल्व हैं, उनका कोई भी डिफिकल्ट टू ट्रीट टीबी क्लिनिक में आप रजिस्टर करा सकते हैं, और उसका भी समाधान हम कर रहे हैं। इन कुछ वर्षों में किंग जॉर्ज मेडिकल यूनिवर्सिटी ने न सिर्फ लीडरशिप एस्टेब्लिश की है, बल्कि चाहे वो आउटरीच प्रोग्राम हो, चाहे एडवोकेसी हो, चाहे वो ट्रेनिंग हो, या इस तरह के अवेयरनेस प्रोग्राम हो, ये सब हम लोग बराबर कर रहे हैं। और इसका जो इम्पैक्ट है वो भी दिखाई दे रहा है कि उत्तर प्रदेश में जो मॉर्टेलिटी है टीबी की वो घट है। बहुत
Sir, for now I invite our partner, Vineet Sharma, sir, Pro Vice Chancellor KGMU, to share his thoughts on the occasion.
Thank you, dear. Honorable and respected Vice Chancellor, Lieutenant General P. Professor Rajendra Prasad, my teacher and guide, Dr. Surya Kant, and the vibrant organizing secretary, Dr. Ved. My dear faculty members, students, members of the press, staff nurses, and our dear ladies and gentlemen. Today is a special day, and that special day has been celebrated in this department under the chairmanship of Professor Rajendra Prasad and Secretary Dr. Ved Prakash. The very theme of the conference and CME, that is to eliminate tuberculosis, and yes, we can do it. I think all the previous mentors have stressed on what the union government wants, what are the programs that are available, and what KGMC has done under the banner of Department of Respiratory Medicine, Pulmonary Medicine, and Critical Care. I must tell you that it is our responsibility also, and as an orthopedic surgeon, I would emphasize on extrapulmonary tuberculosis. Recently, I have seen that we get a lot of treated cases of tuberculosis of the hip, over in which joint replacement is done, but the incidence of spinal tuberculosis has increased. And this is probably because the diagnosis is late, number one, and number two, drug-resistant tuberculosis is a big factor. So if we have to eliminate tuberculosis, it becomes our responsibility as citizens and doctors to notify the disease at a time properly, number one. Number two, to diagnose them early. And I think that is the only way we can eliminate or we can decrease the incidence of tuberculosis as spoken by Professor Rajendra Prasad. So I would like to congratulate the department and especially Dr. Ved for bringing out this CME on this special day, and I wish them all the success for this CME conference. Thank you very much.
Thank you, sir. Now we request our chief guest for the event, Lieutenant General Dr. Bipin Puri, sir, Honorable Vice Chancellor KGMU, for his blessings and message. Thank you.
So, Mr. Rajendra Prasad ji, Vineet Sharma ji, Dr. Suryakant and Dr. Ved Prakash, members, faculty members, respiratory medicine, pulmonary critical care, residents, doctors, friends from the media, भाइयों और बहनों, ladies and gentlemen. सबसे पहले तो मैं प्रोफेसर वेद प्रकाश का धन्यवाद देता हूं, जिन्होंने हमें आज इस बहुत इम्पॉर्टेंट दिन में हमको इस इवेंट के लिए बुलाया है. वर्ल्ड ट्यूबरकुलोसिस डे, जैसा कि आपको मालूम है, 24 मार्च सारे विश्व में एक जागरूकता के तौर पर मनाया जाता है. और मैं समझता हूं कि ये एक बहुत इम्पॉर्टेंट इसलिए है कि ये एक ऐसी बीमारी है, जैसे प्रोफेसर राजेंद्र प्रसाद कह रहे थे, जो क्योरेबल है, उसके बावजूद इतनी भयानक है. मुझे याद है करीब 45 साल पहले जब मैं मेडिकल स्कूल में था, तो उस समय हमें पढ़ाया जाता था कि टीबी एक ऐसी बीमारी है, वो छिप छिप के आपके सामने आती है, आपको डायग्नोज करने में दिक्कत होगी. वो कई तरीकों से आती है आपके सामने और आपको डायग्नोज करना कभी कभी डिफ़िकल्ट हो जाता है. बट टीबी हमारे देश में इतनी उसकी अहमियत है. 45 साल हो गए भाइयों बहनों, बट टीबी ने अगर कहीं आपने उसको कंट्रोल करने की बात आई तो वो किसी और तरीके से आ गई. कुछ मुद्दे हैं, कुछ इश्यूज हैं, कुछ प्रॉब्लम्स हैं, कुछ चैलेंजेस हैं. सारे जो मेंटर्स हैं ट्यूबरकुलोसिस प्रोग्राम के, वो सब यहाँ पर उसको समझ रहे हैं, परख रहे हैं, उसका रिसर्च कर रहे हैं, उसकी प्लानिंग कर रहे हैं, कैसे हम उसको कंट्रोल और इरेडिकेट कर सकते हैं. बट ये जो सफ़र रहा है ट्यूबरकुलोसिस का, पहले कंट्रोल प्रोग्राम और नाउ इरेडिकेशन प्रोग्राम, इसमें प्रॉब्लम्स आई हैं क्योंकि इसमें जैसा कि बताया गया कि इलाज थोड़ा सा लंबा होता है. कई लोग कंप्लायंस कर पाते हैं, दवाई ले पाते हैं, कई लोग कुछ टाइम के बाद बंद कर देते हैं कि थोड़ा सा ठीक हुआ तो अब बंद कर दिया. तो मैं समझता हूं कि ये मल्टीपल रीज़न, चाहे वो पैसे के हों, चाहे वो इकोनॉमिक्स के हों, चाहे वो न्यूट्रिशन के हों, चाहे वो डायग्नोसिस के हों, चाहे वो इलाज के हों, तो बहुत रीज़न्स हैं जिसके कारण ये प्रोग्राम अच्छे से सफल नहीं हो पाया. बट अभी राहत है, अभी टेक्नोलॉजी, फार्माकोलॉजी बहुत एडवांस हो चुकी है. एंड जैसा कि प्रोफेसर सूर्यकांत भी बता रहे थे, नए ड्रग्स आ गए हैं. बट इसके साथ साथ हमारे पास एक और चुनौती है, और चुनौती ये है कि अगर जो ड्रग रेजिस्टेंट ट्यूबरकुलोसिस है या हाईली रेजिस्टेंट ट्यूबरकुलोसिस है, वो हमें बार बार बोलता है कि आपको मेरे बारे में भी सोचना पड़ेगा. नॉर्मल ट्यूबरकुलोसिस तो आप इलाज कर लोगे, बट जो रेजिस्टेंट ट्यूबरकुलोसिस है, आप मेरे बारे में भी सोचना पड़ेगा. पहली बात तो ये. एक और मुद्दा मैं उठाता हूँ, एंड वो है एक्स्ट्रा पल्मोनरी ट्यूबरकुलोसिस. एक तो होता है फेफड़ों की, एक और ट्यूबरकुलोसिस है, चाहे वो ब्रेन का ट्यूबरकुलोसिस हो, चाहे वो बोन का हो, चाहे वो पेशाब के रास्ते का ट्यूबरकुलोसिस हो, चाहे वो पेट की आंतड़ियों का ट्यूबरकुलोसिस हो. जगह जगह के ट्यूबरकुलोसिस हैं. वो ना तो वो इस समय नोटिफाइबल हैं, नोटिफाइबल तो सारी ट्यूबरकुलोसिस है, बट वो होते नहीं. और उनका डायग्नोसिस, उनका इलाज उतना डिफ़िकल्ट होता है। तो मैं समझता हूँ कि ये एक और जो हमारी जो नेशनल टीम है, उनको ये सोचना है कि एक्स्ट्रा पल्मोनरी ट्यूबरकुलोसिस को हम कैसे एनकाउंटर करेंगे, कैसे हम उसका, तो एक तो मैं समझता हूँ कि ड्रग रेजिस्टेंट ट्यूबरकुलोसिस, कंप्लायंस ऑफ ट्रीटमेंट, एक्स्ट्रा पल्मोनरी ट्यूबरकुलोसिस, ये कुछ ऐसे मुद्दे हैं जो एक प्रॉब्लम्स हैं, एक चैलेंजेस हैं, जिनको हमें इनको देखना है। मैं बहुत बहुत बधाई देता हूँ अपने प्रोफेसर वेद प्रकाश, जिन्होंने ये मीटिंग फ्रॉम टाइम टू टाइम ये ऑर्गेनाइज करते हैं, ये जागरूकता के लिए, लोगों तक पहुंचने के लिए, कि बहुत इम्पॉर्टेंट है। आप लोगों को मालूम है ऑनरेबल प्राइम मिनिस्टर ने ये एक कमिटमेंट करी थी कि हम 2025 में इसको इरेडिकेट कर देंगे। हमारे गवर्नर मैडम ऑनरेबल आनंदीबेन पटेल जी ने अपनी तरफ से उत्तर प्रदेश में भी इस अभियान को बहुत आगे बढ़ाया है। और जैसा कि आप लोगों को मालूम है, हम कई कॉलेजेस ने, कई यूनिवर्सिटीज़ ने विलेजेस अडॉप्ट किए हैं, वहाँ पर हम सर्विलेंस प्रोग्राम्स चलाते हैं, हम स्क्रीनिंग प्रोग्राम्स कराते हैं, उनका दवाई उनका मॉनिटर करते हैं। तो मैं समझता हूँ कि ये एक छोटे छोटे सेगमेंट्स, ये छोटे छोटे जो हम लोगों ने अडॉप्ट किए हैं विलेजेस, ये एक प्रोसीजर है, एक सही स्टेप है इन द राइट डायरेक्शन। एंड उत्तर प्रदेश गवर्नर मैडम ने तो किया। केजीएमयू, आप लोग को मालूम है, केजीएमयू में हम लोग ने बच्चों को अडॉप्ट किया, हमने पेशेंट्स को अडॉप्ट किया है, जहाँ पर हम उनका इलाज भी करते हैं, उनको न्यूट्रिशनल सप्लीमेंट्स भी, और जैसे कि गवर्नमेंट की पॉलिसी है 500 रुपये उनके अकाउंट में जमा हो जाते हैं। तो ये एक छोटे छोटे स्टेप्स हैं, बेबी स्टेप्स जिसे हम कहते हैं, बट ये एक सफ़र है। मेरा ये मानना है कि हम सबको हाथ पकड़ के ये अपने सोसाइटी में ये एक जागरूकता लानी है कि हमें न्यूट्रिशन, दवाई का, उसमें कंप्लायंस बहुत ज़रूरी है। एंड अगर हम अपना एक अच्छा वातावरण रखें, साफ़ सुथरा वातावरण रखें, अब इन्फेक्शन स्प्रेड करने के लिए उसके तौर तरीके समझाएं, एजुकेशन हो, एंड आप अगर आपका इलाज है जो आपको करना है, उसको आपको दवाई लेना बहुत बहुत ज़रूरी है। बहुत मुझे खुशी है दैट केजीएमयू हमारा एक नोडल सेंटर है फॉर ट्यूबरकुलोसिस। प्रोफेसर सूर्यकांत उत्तर प्रदेश सारे स्टेट के एसटीएफ के चेयरमैन हैं, और वो सारे स्टेट को ट्यूबरकुलोसिस मुक्त एक प्रदेश की तरफ ले जा रहे हैं। मैं अपने माइक्रोबायोलॉजी डिपार्टमेंट की भी बहुत प्रशंसा करता हूँ। प्रोफेसर प्रशांत हैं, अमिता जैन जी हैं, विमला वेंकटेश हैं, जिन्होंने हमारा मॉलिकुलर डायग्नोस्टिक्स, जो हमारा जो ट्यूबरकुलोसिस, स्पेशली ड्रग रेजिस्टेंट ट्यूबरकुलोसिस को डायग्नोस करने के लिए स्पेशल तरीके तरीके बनाए हैं, एल्गोरिथम्स बनाए हैं कि कैसे उन मरीज़ों का जिनको नॉर्मल दवाइयों से इलाज नहीं हो पाता, उनको हम क्या इलाज करें उनके लिए। तो उनको भी मैं बहुत बधाई देता हूं कि उन्होंने एक स्पेशलाइज सेंटर सारे प्रदेश में, ये इनका जो माइक्रोबायोलॉजी डिपार्टमेंट है हमारा केजीएमयू का, जो इसका डायग्नोसिस कर रहे हैं। मैं इन सब बातों के साथ मैं आज फिर से प्रोफेसर वेद प्रकाश को बधाई देता हूं कि आज हम सब वर्ल्ड ट्यूबरकुलोसिस डे की बात आम आदमी तक पहुंचा रहे हैं। मैं अपने सारे मीडिया बंधुओं को भी मैं धन्यवाद देता हूं। थैंक यू लेडीज एंड जेंटलमैन।
Thank you, sir, for your kind motivation. I now request the organizing secretary for the event, Dr. Ved Prakash, sir, to kindly felicitate our esteemed dignitaries with a memento and a shawl. I request the esteemed dignitaries please come forward. sir to our chief guest, Dr. Puri sir, a shawl and a memento. Dr. Vineet Sharma sir, Pro Vice Chancellor, King George Medical University, UP Lucknow. Professor Rajendra Prasad sir, Organizing Chairman, Ex-Director, BP Chest Institute and Director of Medical Education, Professor in the Department of Pulmonary Medicine, ERA Medical Hospital and College. Professor Suryakant sir, and Head Department of Respiratory Medicine, King George Medical University. I request our chief guest, Lieutenant General Dr. Bipin Puri sir, to kindly felicitate our organizing secretary and head of department, Dr. Ved Prakash sir, with a shawl and memento. Thank you so much, sir.
Now I request to take the seats on the dais. Now I invite our organizing secretary for the event, Dr. Ved Prakash sir, to kindly propose the vote of thanks.
थैंक यू। आज बहुत ही आनंद का दिन है जब हम लोग ऐसे विषय पर चर्चा करने के लिए आप सबके बीच में हैं, जबकि देश में एक ऐसा माहौल है टीबी के खिलाफ जैसे एक वॉर फुटिंग पे पूरे काम चल रहा हो। जैसे प्रधानमंत्री जी के आह्वान से एक जन आंदोलन की तरफ देश आगे बढ़ रहा है टीबी के खिलाफ। टीबी मुक्त भारत अभियान बहुत तेज़ी से जन तक अपनी पहुंच बना रहा है और मुझे विश्वास है कि हम 2025 तक टीबी मुक्त भारत का जो सपना माननीय प्रधानमंत्री जी का है, अब वो सपना हर भारतीय का है। मुझे लगता है कि 135 करोड़ देशवासी भी अब इस सपने को देखने लगे हैं और मुझे लगता है कि 21वीं सदी का भारत सशक्त भारत है और वो टीबी मुक्त भारत जब बनेगा तभी दुनिया में सशक्त भारत की जो परिकल्पना है वो साकार हो सकेगी। इस अवसर पर हमारे लेफ्टिनेंट जनरल डॉक्टर बिपिन पुरी सर, मैं आपका बहुत बहुत धन्यवाद देता हूं कि आप व्यस्ततम समय में से हमारे बीच उपस्थित हुए। आज कई सारे कार्यक्रम आपके लगे हुए हैं सर, लेकिन आपने स्पेशली हमारे लिए वक्त निकाला। मैं आपको बहुत बहुत धन्यवाद देता हूं। हमारे डायनेमिक प्रो वाइस चांसलर सर, जो हमेशा ही हम लोगों के मार्गदर्शन करते हैं और वीसी साहब और हम लोगों के बीच में ब्रिजिंग का काम करते हैं। जब हम हर बात सर से नहीं कह पाते तो हम लोग विनीत शर्मा सर जो हमारे टीचर हैं उन्हीं को हम लोग हमेशा परेशान करते हैं। सर मैं आपको बहुत बहुत धन्यवाद देता हूं कि आप हमारे बीच में हैं। प्रोफेसर सूर्यकांत सर जो एसटीएफ के चेयरमैन हैं और लगातार टीबी के लिए जितना बड़ा अभियान देश में चल रहा है उसमें उत्तर प्रदेश में उसको एक लीडरशिप पोजीशन में ले जा कर के आगे बढ़ाने का काम और जन तक पहुंचाने का काम तमाम तरह के कार्यक्रमों के माध्यम से सर आप लगातार कर रहे हैं। मेरे टीचर हैं, मेरे थीसिस के गाइड भी हैं। मैं आपको बहुत बहुत धन्यवाद देता हूँ सर कि आप हमारे बीच में आए। बहुत बहुत धन्यवाद सर। टीचर ऑफ टीचर्स प्रोफेसर राजेंद्र प्रसाद, जिन्हें हम लोग पितामह की तरह देखते हैं, जिन्हें हम लोग टीबी से किस तरह से ये अभियान चलते चलते पल्मोनरी एंड क्रिटिकल केयर तक पहुंचा है, डीएम कोड से जो उत्तर प्रदेश में शुरू हुए हैं, जो माननीय कुलपति जी के आशीर्वाद से इस विभाग में पहला उत्तर प्रदेश का डीएम कार्यक्रम प्रारंभ हुआ। आज तीनों बैच सर आ चुके हैं और कई तरह के जो एक साल के प्रोग्राम हैं वो भी चल रहे हैं, और इन सब के पीछे जो गाइडिंग फोर्स है, मुझे लगता है कि यहाँ तक जर्नी को यहाँ तक लाने के लिए प्रोफेसर राजेंद्र प्रसाद सर हमारे बीच में हैं। हमेशा ही वो समय देते हैं। मैं आपका बहुत बहुत धन्यवाद देता हूँ सर। हमारे टीचर्स प्रोफेसर आर.एस. कुशवाहा सर, प्रोफेसर राजीव गर्ग सर, माइक्रोबायोलॉजी से प्रोफेसर प्रशांत, प्रोफेसर राज कल्याण, डॉक्टर दर्शन, हमारे साथ में डॉक्टर अशोक यादव जी जो कि बहुत ही रिनाउंड फिगर हैं स्टेट में, आप सबका मैं धन्यवाद देता हूं। डॉक्टर के सावलानी सर जो मेडिसिन के प्रोफेसर हैं, आपका भी मैं सर बहुत बहुत धन्यवाद देता हूं कि आप अपनी टीम के साथ यहां पर हम लोगों के बीच में हैं। हमारे समस्त स्टूडेंट्स, रेजिडेंट्स, सभी विभागों के रेजिडेंट्स, और जो हमारे नर्सिंग पैरामेडिक्स, उन सभी का भी मैं धन्यवाद देता हूं। हमारे मीडिया के साथी, क्योंकि ये जो प्रधानमंत्री का सपना है, ये सपना कैसे हर भारतीय का सपना बन रहा है, इसमें एक बहुत बड़ी महत्वपूर्ण भूमिका वो चौथे स्तंभ की है। और मुझे खुशी है कि आज आप इतनी बड़ी संख्या में माननीय कुलपति जी के इस आशीर्वचन को कवर करने के लिए और इस प्रोग्राम को कवर करने के लिए आप बड़ी संख्या में हमारे बीच में हैं। मैं आपको बहुत बहुत धन्यवाद देता हूं। और जितने भी हमारे सपोर्ट करने वाले ग्लेनमार्क या और भी जो बैक स्टेज टीम है, मैं आपको भी बहुत बहुत धन्यवाद देता हूं। अंत में सभी का धन्यवाद देता हूं। बहुत बहुत धन्यवाद।
I now request everyone to please rise for the national anthem.
जनगण मन अधिनायक जय हे, भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा, द्राविड़ उत्कल बंग, विंध्य हिमाचल यमुना गंगा, उच्छल जलधि तरंगा। तब शुभ नामे जागे, तब शुभ आशीष मांगे, गाए तब जय गाथा। जनगण मंगलदायक जय हे, भारत भाग्य विधाता। जय हे, जय हे, जय हे, जय 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 हे।
We will shortly start with the academy, so please remain seated. He is professor in the Department of Internal Medicine, KGMU. Dr. S.K. Singh, sir. He is professor in the Department of Community Medicine. Dr. Darshan Bajaj, sir. He is additional professor of Respiratory Medicine, KGMU. And Dr. Sachin Kumar, sir. Assistant professor, Department of Pulmonary Critical Care, KGMU. Please, sir.
So, a very good afternoon to all of you. Now, as we know, has been discussed, there were 10.6 million cases of TB in 2021. There was a rise of 4.5%. There were 10.1 million cases. We all know there are 1.5 million deaths each year. It is the leading of death in people with HIV also. And 20%, 28% of cases in India. India is amongst the top countries accounting for nearly 65% cases of TB. And it is also a leading cause of antimicrobial resistance. There were 450,000 cases of rifampicin resistance in 2021. So these are some data which I have got through WHO website. And to discuss more about this epidemiology of tuberculosis in India, I invite Dr. Prashant Bajpayee, who is Assistant Professor in Department of Community Medicine, Lucknow. And he will present to you epidemiology of tuberculosis in India, changes through years.
All of you, respected teachers, faculty members, and residents present, and all the persons present in the hall. I am Dr. Prashant Bajpayee, Assistant Professor in the Department of Community Medicine and Public Health, KGMU. And I am going to present the epidemiology of tuberculosis in India, the changes through years. I will discuss about changes in last decade. The objectives of this session are a short history, burden of the disease, changes in the epidemiology of tuberculosis, of TB statistics in India, and steps undertaken India to achieve end TB by 2025. So first, I'm going to tell you a short history of tuberculosis as already discussed in the very introductory session by our residents. It has been hypothesized that the genus Mycobacterium originated more than 150 million years ago. And the recent studies under molecular genetics now suggested that human tuberculosis, Mycobacterium tuberculosis, pre-existed that in other animals, including cattle or bovine tuberculosis. It is one of the most fatal and killer disease, all previously known as white plague in the Middle Ages, because of patients going pale due to the tuberculosis. If we go through the ancient history, in the disease क्षयमा या क्षय रोग जिसे हम कहते हैं, और the king's disease, किंग्स डिसीज इसलिए इंडियन हिस्ट्री में बोलते हैं क्योंकि पहले यहाँ पर जो सबसे पहले जो इफेक्ट हुए थे, इंडियन माइथोलॉजी में जो बोला जाता है मून गॉड या चंद्रदेव, जिन्हें सोमदेव कहा जाता है, उनके नाम पर ये पढ़ा गया है। तो ये एक सिंबॉलिक प्रेजेंटेशन, चूँकि चंद्रमा की 27 कलाएँ होती हैं और चंद्रमा धीरे धीरे क्षय होता जाता है, जो उसका आकार देखा गया है। तो दिस वॉज a symbolic presentation. Also, the literature in China and Egypt showed that there was the Mycobacterium tuberculosis present in these days. In ancient Hebrew, it is called as ischephet, and in Roman Empire, it was known as stabis. And the TB of neck and lymph nodes was commonly referred to as scrofula. In the ancient Greece, it was known as phthisis, where the Hippocrates in the book of epidemics described the disease of weakness of lung. Also in the cases of England and France, the illness was known as King Civil, or captain of all these men of death. Finally, in 1834, J.L. Schonlein from Germany suggested the word tuberculosis and brought to an end of multiplicity of names of tuberculosis. बहुत सारे नाम हो गए थे, तो finally 1834 में इन्होंने एक term coin किया, tuberculosis. Now coming to the burden of that disease, tuberculosis, every year WHO publish a report. The report published by WHO is known as Global Tuberculosis Report. Last report published was on 2022. गवर्नमेंट ऑफ इंडिया ने पिछले साल एक रिपोर्ट पब्लिश की है, ये हर साल पब्लिश होती है। 2022 का डेटा ही अभी तक अवेलेबल है वेब। एक और चीज़ डिस्कस करना चाहूँगा, एपिडेमियोलॉजी से थोड़ा सा अलग है। ये आपकी ग्लोबल ट्यूबरकुलोसिस रिपोर्ट एंड टीबी है, वो WHO द्वारा डेवलप किया गया है, जो आप अपनी हैंड हेल्ड डिवाइसेस में इंस्टॉल कर सकते हैं। और इसमें सारे ग्लोबल डेटा हैं, चाहे वो ग्लोबल या कंट्री, आपके हैंड हेल्ड डिवाइसेस पे इंस्टेंटली। This map graph is showing the burden of tuberculosis globally. In 8 countries, comprises of 68% of global cases, as was presented in the Global Tuberculosis Report last year. You can see here in India, the burden is very high, more than 2 lakh cases per year. Sorry. The global burden, it is one of the world's deadliest disease, as I already discussed. Each day, close to 4,400 people die of this disease. और हर दिन 30,000 लोग बीमार होते हैं with this preventive and curable disease. जैसा सर कह रहे थे अभी कि ये totally curable disease है. A total of 1.6 million people died from tuberculosis in 2021, including the PLHIV, that is people living with HIV. एक काफ़ी इंटरेस्टिंग डेटा है, ग्लोबली क्लोज टू हाफ ऑफ टीबी अफेक्टेड हाउसहोल्ड्स फेस कॉस्ट हायर देन 20% ऑफ देयर हाउसहोल्ड इनकम। बहुत सारा उनका जो आय का जो सोर्स है वो बहुत सारा पोर्शन, मोर देन 20%, आप समझ सकते हैं, टीबी को ट्रीट करने में या उससे कॉम्बैट करने में खर्च हो जाता है। और only about 1/3 of the people with drug resistant TB access the treatment in 2020. अगर हम एपिडेमियोलॉजी की इसमें बात करें, more than 40% of population in India carry tuberculosis infection. इन्फेक्शन 40% को है, लेकिन ये डिसीज में लगभग 10% लोगों को कन्वर्ट होता है। And it is one of the most common cause of infertility in our country. Out of the total global cases, more than 26%, 26 to 28%, कई जगह डेटा में मिलेगा 30, even 30% cases are from India. लगभग 1/3 cases इंडिया के हैं, including the both MDR and HIV/TB cases. These are the estimated TB burden in the Global Tuberculosis Report from 2019-20 to 21. The total TB incidence in 2019 was 193, while in year 2020 it was 188. Again, there was a surge, upsurge in the TB cases. It surged up to 210 cases. The causes are many. Either maybe due to more reporting of the cases or due to COVID pandemic. Then HIV positive TB incidence. It was 2.7 in 2019, 3.8 and 3.9 in the year 2021. The HIV TB mortality was 0.96. There was a dip in 2020. It came to the 0.78, and then there was a rise up to the 0.81. But in MDR TB incidence, there was a decline from 2019 to the year 2021. It was 9.1 in the year 2019, and it was 8.5 in the year 2021. अगर हम टीबी के नोटिफाइड केसेस की बात करें तो परसेंटेज ऑफ टोटल टीबी केसेस जो भी नोटिफाइड होते हैं उसका 6% कंप्राइज होता है पीडियाट्रिक पॉपुलेशन से फ्रॉम 0 to 14 ईयर्स और एडोलेसेंट पॉपुलेशन कंप्राइजेस अराउंड 13%. तो अगर इन्हें हम टोटल करें तो लगभग 19 से 20% केसेस नोटिफाइड हो रहे हैं, वो हमारे पीडियाट्रिक से लेके एडोलेसेंट पॉपुलेशन तक के हैं. तो एक बहुत डिफ़िकल्ट एरिया है बच्चों को और एडोलेसेंट्स को कैच करने के लिए. A study published in the BMJ in 2019 using NFHS4 data showed that self-reported point prevalence of 304 patients per lakh population, and the private sector was an important source of care. It means here that how much people are aware of the disease. 304 patients aware हैं इस disease के, and how many of them are breaking the social stigma associated with the tuberculosis and getting the treatment. तो सेल्फ रिपोर्टेड प्रेवलेंस जितना भी ज़्यादा जिस कम्युनिटी में होगा उतना ही हमारे लिए बेटर होगा, क्योंकि पेशेंट उतने ही ज़्यादा अवेयर हैं और वो सोशल स्टिग्मा को ब्रेक करके ट्रीटमेंट के पास तक पहुंच रहे हैं. Now coming to the trends in the estimated TB incidence rates in the last 2 decades, the graph is showing the data from year 2000 till year 2020. The blue line is TB incidence rate. You can obviously see that there is a continuous decline in the TB incidence rate till the year 2019. But there is an upsurge in TB cases in the year 2020. Similarly, the black shows the TB case notification rate. There is this constant increase in the TB notification, and there is till the year 2019, and in year 2020 it was declined. If we talk about the trends in estimated TB deaths, including both HIV positive and HIV negative TB in India, from year 2020, last 2 decades, there was constant decline from the year 2000 to the year 2019. But there was upsurge in the year 2020, most probably due to this COVID pandemic. Coming to the in the estimated number of incident cases of MDR or rifampicin resistant TB. The data is from the year 2015 to 2021. There is constant decline in the number of incident cases of MDR TB, but from the year 2020 to 2021, this upward trend was seen. Now, coming to the changes in the epidemiology of tuberculosis, all we know that we study the agent factors, host factors, and environmental factors in the epidemiology of any disease. It is the study of distribution and determinants of health-related diseases or events. So, if we talk about the agent factors, nowadays you all are aware that many of cases are drug resistant. In any disease, जो बैक्टीरियल इन्फेक्शन हो रहे हैं, एजेंट फैक्टर्स में कुछ जेनेटिक चेंजेस हो रहे हैं, चाहे वो ड्रग एब्यूज़ की वजह से हो, ओवर यूज़ हो, माइक्रोबायोलॉजिकल एजेंट्स, एंटी माइक्रोबियल ड्रग्स का, तो कुछ चेंजेस तो हो रहे हैं एजेंट्स में, जिस वजह से हमारा माइकोबैक्टीरियम ट्यूबरकुलोसिस का बैक्टीरिया ख़त्म करने में दिक्कत आ रही है हमें. इसी से रिलेटेड एक स्टडी पब्लिश हुई थी SGPGI में. ये स्टडी हुई थी मार्च 70 से जून 2019 तक. द असेसमेंट ऑफ बर्डन ऑफ ड्रग रेजिस्टेंट ट्यूबरकुलोसिस एट ए टर्शरी केयर सेंटर इन नॉर्दर्न इंडिया, ए प्रोस्पेक्टिव सिंगल सेंटर कोहॉर्ट स्टडी. इसमें ये देखा गया लगभग 22% जो केसेस थे वो रिफैम्पिसिन मोनो रेजिस्टेंट केसेस थे. And out of 62 cases included for second line testing, 48 were resistant for fluoroquinolones, around 78%, while 11 cases were extensively drug resistant. तो आप देख रहे हैं एजेंट में कैसे चेंजेस आ रहे हैं. दूसरा फैक्टर होता है एपिडेमियोलॉजी में होस्ट फैक्टर. इसका एक अच्छा सा एग्जाम्पल देना चाहूँगा आपको. नॉर्थ ईस्ट स्टेट्स जो इंडिया की हैं, वहाँ पर टीबी का प्रेवलेंस बहुत ज़्यादा हाई है. तो अभी मैं स्टडी एक बैठे बैठे पढ़ रहा था, तो एक क्यूरियस में पब्लिश हुई है. स्टडी का नाम मैं शायद थोड़ा सा भूल रहा हूँ. तो वहाँ पर उस स्टडी में जो भी केसेस लिए गए थे, उसमें मोर देन 50%, अराउंड 54% केसेस में ये देखा गया कि वो डायबिटीज़ मेलाइटिस प्रेजेंट था. तो दीज आर सम चेंजेस इन आवर. कौन है? ह्यूमन. तो डायबिटीज़ मेलाइटिस हो, चाहे हाइपरटेंशन हो, क्रॉनिक डिसीजेज हो, मेल न्यूट्रिशन, एल्कोहल एब्यूज़, ये सब, और सोशल इनइक्वालिटी, ये भी एक कॉज है होस्ट फैक्टर में चेंजेस का. तीसरी हम बात करें एपिडेमियोलॉजिकल ट्रायड में एजेंट होस्ट के बाद इन्वायरमेंटल फैक्टर्स. आजकल हम सभी लोग देख रहे हैं, अब अगर हम देखें अपने स्कूल, जो आपके बच्चे जाते हैं स्कूल्स में, क्लोज्ड क्लासरूम्स हैं, एसी कार में चल रहे हैं, शीशे ऑन कर लिए, चढ़ा लिए, ड्राइवर के साथ बैठे हुए हैं. इन्वायरमेंटल चेंजेस हम स्वयं कर रहे हैं. एसी रूम्स में बैठ रहे हैं, नेचुरल एयर का वेंटिलेशन ख़त्म कर दिया है. जबकि आप किसी भी ड्रग रेजिस्टेंट टीबी वार्ड में जाइए, वहाँ पर किस तरीके का वेंटिलेशन होता है, एग्जॉस्ट लगे रहते हैं बाहर की तरफ. These are some environmental factors that we have changed. तो हमें इस पर भी एक ध्यान देना होगा कि एजेंट, होस्ट और एनवायरनमेंट ये प्ले कर रहे हैं रोल. ऑब्वियसली टाइम इज ऑल्सो इन्वॉल्व, क्योंकि टाइम के साथ ही ये चेंजेस हो रहे हैं. तो ये ऑफ एपिडेमियोलॉजी होता है, एजेंट, होस्ट एंड एनवायरनमेंट इंक्लूडिंग टाइम. तो इस चेंजेस को हमें पकड़ना होगा और देखना होगा क्या चेंजेस हुए हैं, जिस वजह से हम इस टीबी जो क्योरेबल डिसीज़ है वहाँ तक इसे एंड करने के पास तक नहीं पहुँच रहे हैं. Now coming to the updates of TB statistics in India in terms of incidence, prevalence, notification, mortality, and other relevant data. I have summarized some important variables from the NFHS 4 data that was conducted during the year 2015 to 2016 and NFHS 5 data 2019 से 21 का ये डेटा है। तो इसकी कुछ important variables जिनमें changes significant देखे गए थे। एक वेरिएबल है उसमें एज का, more than 60 years of age का जो एज ग्रुप है उसमें NFHS 4 में डेटा था 894 जो प्रेवलेंस है। NFHS 5 के डेटा में ये कम होके 586 में रह गया है, लेकिन अभी भी ये जो एज ग्रुप है सबसे ज़्यादा हाईएस्ट प्रेवलेंस का एरिया है जो वेरिएबल है। इसके बाद अगर हम बात करें कुछ स्टेट्स की, इंडिया में सबसे कम टीबी कहाँ पर पाई जाती है, तो इस डेटा में मुझे ये मिला चंडीगढ़, स्टेट नहीं आप एक सिटी कह लीजिए इसे, 89 से 24 कम हुआ है। अरुणाचल प्रदेश, नागालैंड, मेघालय, नॉर्थ ईस्ट स्टेट, इन्हें टी स्टेट्स ऑफ इंडिया कहते हैं, वहाँ पर प्रेवलेंस बहुत ज़्यादा है। इस समय जो हाईएस्ट प्रेवलेंस है वो है नागालैंड में, जो जबकि NFHS 4 का डेटा कह रहा था अरुणाचल प्रदेश। एक इंटरेस्टिंग चेंज आया है गोवा में। NFHS 4 का डेटा, it showed that the prevalence was only 74, while in the NFHS 5 data, you can clearly see there is sharp rise in number of cases or prevalence. Factors बहुत सारे हो सकते हैं, हो सकता हो कोविड-19 हो जो पैंडेमिक हुआ है, या हमारी कुछ वहाँ पे जियोग्राफिकल चेंजेस हो, या फिर एक और इंटरेस्टिंग थिंग हो सकती है रिपोर्टिंग अच्छी हो गई हो। तो मेनी फैक्टर्स हैं वो रिसर्च एरिया के लिए अच्छे हैं। देन कमिंग टू द टीबी नोटिफिकेशन, I have taken this data from the NICSHE website 3 days back. You can clearly see here that in private sector, the TB notification was significantly increased from 14 to 77 from the year 2017 to the year 2022. बहुत ज़्यादा नोटिफिकेशन रेट बढ़ गया है प्राइवेट सेक्टर में, जो अब तक नहीं हो रहा था। इस डेटा में एक और आप देख रहे होंगे जिस पे मैंने रेड सर्कल बना रखा है 2020 टू 2021। इस समय पर हमारा जो टीबी का नोटिफिकेशन है ये कम हुआ ड्यू टू कोविड पैंडेमिक। मैं बार बार कोविड पैंडेमिक का नाम ले रहा हूँ, एक बहुत इंटरेस्टिंग स्लाइड आपको दिखाऊंगा आगे, उस ड्यूरेशन में अच्छा क्या हुआ। एंड यू कैन एक्सेस दिस डेटा फ्रॉम द NICSHE website and especially focus on the Uttar Pradesh.
Dr. Prashant, 20 minutes have elapsed, so please make haste.
Sir, in UP, you can see that private sector has shown a significant improvement in the data. Likewise, in these slides, in दोनों slides में आप देखेंगे year 2020 और 2021 में ड्रग सेंसिटिव टीबी का नोटिफिकेशन अप्रैल और मई में कम हुआ। टीबी नोटिफिकेशंस भी अप्रैल और मई में 2020 और 2021 में कोविड पैंडेमिक की वजह से कम हुए। सिमिलरली इन द पीडियाट्रिक टीबी केस नोटिफिकेशन ईयर 2020 और 2021 में टीबी नोटिफिकेशन कम हुआ है। These are the estimated incidence of all forms of TB. There is constant decline from the year 2010 to 2020. Likewise, the estimated mortality rates, it's sharp decline है 2019 तक, then there was upward surge. इस स्लाइड की मैं बात कर रहा था। कोविड पैंडेमिक में सब चीज़ें शार्प राइज हुए हैं, चाहे वो नंबर हो, टीबी के केस नोटिफिकेशन कम हुए हैं, लेकिन जो ट्रीटमेंट सक्सेस रेट रहा है, देयर वॉज कॉन्स्टेंट अपवर्ड ट्रेंड वॉज सीन डिस्पाइट ऑफ द कोविड पैंडेमिक। इन दो स्लाइड्स में भी यही दिखाया गया है। चाइल्ड इम्यूनाइजेशन हमारा BCG का कम हुआ है, डॉट्स रजिस्ट्रेशन ईयर 2020 में डिक्लाइन हुए थे, एंड व्हाट वी आर डूइंग टू अचीव द एंड TB बाई 2025। तो इंडिया ने काफ़ी कुछ किया है. इंडिया अकाउंट्स फॉर द हाईएस्ट शेयर ऑफ ग्लोबल रिडक्शन 41% in the reported number of people newly diagnosed with tuberculosis, as you can see here. And the journey started from the NTP, and currently we are focusing on the NSP. These were the core impact indicators. 4 core impact indicators were incidence rate, the prevalence rate, to reduce the estimated mortality rate, and to ensure no family should suffer catastrophic cost due to TB. तो सर इस स्लाइड के बारे में जिक्र कर रहे थे अभी आपसे थोड़ी देर पहले कि 217 से 44 डेटा लाना है हमें. India's commitment to end TB, TB हारेगा देश जीतेगा. This is the bold commitment of global importance since India accounts for 26% of the global tuberculosis burden. Thank you, sir.
सर पहले ही पूछे.
Sir.
Prashant, really, you presented very well. I have one query to you and one, addition. This NHFS data, how they derived that this was tuberculosis? What was their method?
Sir,
Because you must be knowing.
case definitions पहले वो ड्राइव करते हैं, फिर सस्पेक्टेड केसेस और प्रिजम्पटिव केसेस में केस डेफिनेशन बना के फिर डेटा कलेक्शन करते हैं.
नहीं, जरा पढ़ना है इसको कि कभी कभी वहाँ ये करते पूछ लेते हैं
Definitely,
कि
sir.
घर में टीवी है कि नहीं है.
Sir, I will read, sir.
And for your addition,
Sir.
there was a one national TB prevalence survey done in India,
Sir.
which was published last year, in 2021. So you can add to it. That will be a wonderful data.
Thank
आइए
you, sir.
मैडम आइए.
Thank you, sir.
हाँ हाँ आइए.
बिल्कुल सर, मैं उसे देखूंगा.
Thank you.
सर बिल्कुल देखूंगा सर मैं उसको.
Thank you very much.
Okay, sir. Thank you, sir.
I welcome the respected faculty members who have just joined, and I am thankful, and it was a very nice presentation, Dr. Prashant Bajpayee. And
Thank you, sir.
actually we could not take other questions because we are already running short of time. So at this juncture, we will like to end this session. Thank you very much.
Thank you, sir.
Thank you, speakers and chairpersons, for conducting this event session beautifully. Now I request Prakash sir to kindly honor our speakers and chairperson for this session. I request him to kindly hand over a memento to our speaker for this session, Dr. Prashant sir. I request our chairpersons to kindly join in that. हाँ, यहीं पे. Now I request Dr. Ved Prakash sir and Dr. Rajendra Prasad sir to kindly honor our chairpersons for this session. Dr. K.K. Savlani sir. Dr. S.K. Singh sir. Dr. S.K. Singh sir. Dr. Darshan Kumar Bajaj sir. Dr. Sachin Kumar sir. Thank you, sir. Now I'd like to invite the chairpersons for the next session. Dr. Rajiv Garg, sir, Professor Respiratory Medicine, KGMU. Dr. Shailendra Kumar, sir, Professor Thoracic Surgery, KGMU. Dr. Kumar, sir, Professor General Surgery, KGMU. Dr. Anand Kumar, sir, Additional Professor Respiratory Medicine, KGMU.
ये मेरी फाइल है।
Yeah, Dr. Kuswaha.
गुड आफ्टरनून। सबसे पहले मैं अपने
राजेश वर्मा सर हमारे बीच में हैं, मैं उनसे रिक्वेस्ट करूंगा कि सेशन शेयर कर लें, बहुत इंपॉर्टेंट है। एक्स्ट्रा पल्मोनरी टीबी कवर होगा, आपकी इनसाइट मिलेगी, बहुत अच्छा होगा सर। प्लीज़ कम ऑन सर, प्लीज़ कम, आ जाइए, है जगह है वहाँ पे, आइए तो आ जाइए। इतनी रिक्वेस्ट हम लोग कर रहे हैं सर आपसे, आइए आप, हमारे इसकी शोभा बढ़ जाएगी आपके होने से।
सो वेलकम डॉक्टर राजेश वर्मा सर। सबसे पहले मैं अपने टीचर प्रोफेसर राजेंद्र प्रसाद सर और डॉक्टर वेद प्रकाश का आभार व्यक्त करना चाहूँगा कि मुझे बहुत ही अच्छा मौका दिया कि इस मौके पे बहुत ही इम्पोर्टेंट टॉपिक है एक्स्ट्रा पल्मोनरी ट्यूबरक्लोसिस। अभी आपने ऑनरेबल वाइस चांसलर सर को सुना, प्रोफेसर राजेंद्र प्रसाद सर को सुना, प्रोफेसर विनीत शर्मा सर ने भी इसको कहा था कि ये अपने इनाग्रल टॉक में बताया कि एक्स्ट्रा पल्मोनरी एरिया इज़ अ वेरी इंपॉर्टेंट एरिया टू एड्रेस। जैसा कि आप अभी माइकोबैक्टीरियम ट्यूबरक्लोसिस की महिमा के बारे में अभी प्रीवियस स्पीकर ने बताया कि कितने हज़ारों लाखों साल से वो उसकी मौजूदगी है और उसकी इफ़ेक्टिव ड्रग्स भी आज की तारीख में, पर फिर भी ये एक पब्लिक हेल्थ प्रॉब्लम है। और जो टीबी का बैक्टीरिया है, जैसे पूरी दुनिया में विश्वव्यापी समस्या है टीबी की, इसी तरह ये शरीर के इंसान का भी कोई कोना छोड़ता नहीं है। तो ट्यूबरक्लोसिस शरीर के किसी भी भाग में हो सकती है। सो दिस टॉपिक इज़ वेरी रेलिवेंट एंड इम्पॉर्टेंट। सो हाउ मच इज़ द मैग्नीट्यूड ऑफ दिस प्रॉब्लम? जो टोटल टीबी है उसका 15 से 20% एक्स्ट्रा पल्मोनरी टीबी होती है और टोटल टीबी का करीब 15 से 20% है। इसमें जो मैक्सिमम पार्ट है आप देखते हैं लिम्फ नोड टीबी और प्लूरल टीबी है। ये जो जो HIV निगेटिव पॉपुलेशन का डेटा है 15 से 20%, और जो HIV पॉजिटिव है उनमें इसका इंसिडेंस और ज़्यादा होता है, अराउंड 50%, समटाइम्स इवन मोर इट कैन बी। एंड एक्स्ट्रा पल्मोनरी एरिया अगर पल्मोनरी TB से कंपेयर करेंगे तो पॉसिबल स्टेट होती है, और इससे रिलेटेड इसके प्रेजेंटेशन में भी आप देखते हैं कि कई बार बहुत लेस एग्रेसिव प्रेजेंटेशन होता है। सो अगर एमंग द एक्स्ट्रा पल्मोनरी TB अगर आप देखेंगे तो लिम्फेटिक TB अराउंड 40%, प्लूरल TB अराउंड 25 to 30%, बोन एंड जॉइंट TB अराउंड 10%, एंड जेनिटोयूरिनरी TB 9%, then miliary TB and meningeal TB around 6% incidence is there. एक्स्ट्रा पल्मोनरी एरिया के कई चैलेंजेस होते हैं, जैसे डायग्नोस्टिक एरिया में, ट्रीटमेंट एरिया में, और इसकी मॉनिटरिंग ऑफ द ट्रीटमेंट, सो इट इज़ समटाइम्स वेरी चैलेंजिंग. समटाइम्स यू विल इनकाउंटर पैराडॉक्सिकल रिएक्शंस ड्यूरिंग द ट्रीटमेंट. इंडिया इसे ट्यूबरक्लोसिस से आपने अभी डेटा देखा कि सबसे प्रभावित देशों में से एक देश है, और हमारा मतलब इंसिडेंस बहुत ही ज़्यादा है, मॉर्टलिटी ज़्यादा है, मॉर्बिडिटी ज़्यादा है यहाँ पे. इसके लिए हमारे कंट्री में जो नेशनल थिंकर्स हैं, लीजेंड साइंटिस्ट हैं, जो टॉप गन्स हैं, लाइक प्रोफेसर राजेंद्र प्रसाद, प्रोफेसर सूर्यकांत, और बहुत सारे और भी थिंकर्स, उन लोगों ने एक गाइडलाइन तैयार की जो इंडियन गाइडलाइन है, जिसे इंडेक्स गाइडलाइन के नाम से जाना जाता है. दिस इज़ कंप्लीट एविडेंस बेस्ड साइंटिफिक डॉक्यूमेंट रिगार्डिंग दिस एक्स्ट्रापल्मोनरी ट्यूबरक्लोसिस. इट टॉक्स अबाउट द एज ए होल all kinds of extrapulmonary tuberculosis, how to make the diagnosis, how to monitor treatment, what are the regimen, especially how long should be treated. कई बार जैसे अभी बहुत शुरू में हम प्रोफेसर प्रसाद सर के साथ हम जब RNTCP प्रोग्राम जैसे जैसे इवॉल्व हो रहा था, तो काफ़ी दिनों तक मैंने काम किया था, तो उस समय जैसे पल्मोनरी चेस्ट पीपल को तो काफ़ी अच्छे से मालूम था कि कितने दिन इलाज करना है, क्या रेजिमेन हो, किस तरह से हो, लेकिन बाकी जैसे और स्पेशलिटीज़ में बड़ा कन्फ्यूज़न था. जैसे कोई जैसे सपोज आर्थोपेडिक्स वो कहते थे हम 1.5 साल 2 साल 3 साल ट्रीटमेंट करते हैं, तो ड्यूरेशन वाज ए वेरी बिग क्वेश्चन कि कितना दिन इलाज करते हैं. डायग्नोसिस के बारे में भी काफ़ी कन्फ्यूज़न था. सो दिस डॉक्यूमेंट इज़ वेरी साइंटिफिक डॉक्यूमेंट, एंड everybody should go through this. It is in very detail and very important document, Index TB Guidelines. It was evolved in 2016. इसमें जो 10 पॉइंट्स हैं, जो इसके की प्रायोरिटी एरिया, जो प्रिंसिपल कहेंगे कि इसके प्रिंसिपल क्या होने चाहिए एक्स्ट्रापल्मोनरी TB को हैंडल करने के लिए. पहली बात है, मरीज़ को बहुत प्राथमिकता दी जाती है, उसके साथ बहुत इज्जत से पेश आना है. सो पेशेंट्स फर्स्ट. देन नेक्स्ट पॉइंट इज प्रमोटिंग अर्ली डायग्नोसिस, एक्सेस टू टिश्यू बेस्ड डायग्नोसिस, एड्रेस ड्रग रेजिस्टेंस, स्पेशली जो एक्स्ट्रापल्मोनरी एरिया में भी आप देखेंगे कि देर आर सम केसेस हु डेवलप ड्रग रेजिस्टेंस, so that should be properly addressed. तो इस गाइडलाइन में ड्रग रेजिस्टेंस को भी एड्रेस किया गया. एक्सेस टू अवॉइडिंग अननेसेसरी टेस्ट, जैसे आपको अननेसेसरी टेस्ट नहीं कराना, ऐसा नहीं कि डे 1 पे ही सारे कॉस्टली टेस्ट, इन्वेसिव टेस्ट आप कर लीजिए. सो यू हैव टू बी वेरी केयरफुल. एक्सेस टू HIV टेस्टिंग, फाइंडिंग एक्टिव पल्मोनरी ट्यूबरक्लोसिस. सो एक ये भी देखना कि एक्स्ट्रा पल्मोनरी TB का कोई केस आता है, तो यू शुड साइमल्टेनियसली आल्सो सी फॉर वेदर द इंडिविजुअल आल्सो हैविंग पल्मोनरी TB और सो वो भी देखना कि कोई एग्जिस्टिंग पल्मोनरी TB है या नहीं है. इंश्योरिंग इफेक्टिव ट्रीटमेंट, प्रमोटिंग अडियरेंस टू ट्रीटमेंट. जैसे पल्मोनरी हो या एक्स्ट्रा पल्मोनरी हो, अडियरेंस इज ए वेरी बिग इश्यू, क्योंकि ये लंबा इलाज चलता है, तो मरीज़ को बहुत अच्छे से मोटिवेट करना है, उसको डे 1 पे उसे डिजीज़ का और उसके प्रोग्रेस का आपको आउटलाइन बताना है कि क्या रहेगा, कैसे रहेगा. सो हमें याद है कि जैसे अगर देखा जाए तो जैसे प्रोफेसर प्रसाद का कोई मरीज़ हो, चेस्ट आई मीन किसी का हो, जो अगर सही से मरीज़ को हैंडल कर रहा है, उसे एक्सप्लेन कर रहा है, समझा रहा है, तो हार्डली कोई मरीज़ शायद डिफ़ॉल्ट करता है. तो मरीज़ को सब कुछ इन्वॉल्व करना है, उसको बताना है, उसके परिवार को बताना है, समझाना है, जैसे पल्मोनरी एरिया में आपको परिवार को ये भी कहना कि किस तरह से बाकी लोगों का बचाव हो, ऐसा ना कि उनमें भी स्प्रेड कर जाए। तो ये सब इशूज़ हैं, आई मीन उनको बहुत ही बढ़िया से हैंडल करना है और फ्यूचर के बारे में बताना है। प्रमोटिंग अरेरेंस आई टॉक, देन रिकॉर्ड कीपिंग, जैसे प्रोग्राम जो नेशनल प्रोग्राम चल रहा है उसमें रिकॉर्ड कीपिंग बहुत ही बढ़िया से की जाती है। और इसका जो एक पूरा नेशनल नेटवर्क है, पूरा हर चीज़ का नेटवर्क एक्स्ट्रा पल्मोनरी टीबी है। हमारी हर कोशिश होनी चाहिए बैक्टीरियोलॉजिकल डायग्नोसिस बन पाए। अगर ये हो जाएगा तो बहुत उसमें अच्छा रहेगा, मॉनिटरिंग और एवरीथिंग वेरी मच क्लियर। So sample should be subjected to microbiological diagnosis, cytopathological and histopathological methods, जैसा आपको सैंपल मिलता है। Detailed investigation you can see that in this. अगर lymph node का केस है, FNAC, lymph node biopsy, FB smear of the aspirate, culture and histology and molecular test. Gene expert is a molecular test. देन इंट्राएब्डोमिनल अगर सैंपल में इंट्राएब्डोमिनल टीबी में FNAC बायोप्सी, एक्सीजन एंड कल्चर गाइडेड प्रोसीजर्स डिपेंडिंग अपॉन द सैंपल आई मीन। देन प्लूरल एस्पिरेट, FB स्मीयर, टोटल लिम्फोसाइट काउंट, डिफरेंशियल काउंट, बायोकेमिस्ट्री, कल्चर, बायोकेमिस्ट्री आई मीन प्रोटीन, sugar cells and this ADA, culture, biopsy and molecular tests, they are important. Renal and urinary tuberculosis, urine for AFB and smear culture and biopsy and this molecular test, they are important. In case of urine, I mean genital urinary tuberculosis, if there is a sterile pyuria, जैसे आपको यूटीआई हुआ तो हम पायोजेनिक बैक्टीरिया के लिए कल्चर सेंसिटिविटी भेजते हैं, उसमें बैक्टीरिया दिख जाता है, लेकिन इसमें अगर एएफबी के लिए देखा जाए तो यूजुअली मुश्किल पड़ता है क्योंकि ये उसमें नंबर ऑफ बैसिलाई इज वेरी लेस. सो सेंट्रीफ्यूज करके उसको प्रोसेस करेंगे, देन यू मे बी सक्सेसफुल. देन ट्यूबरकुलोसिस मेनिंजाइटिस, CSF इज इम्पॉर्टेंट सैंपल. बोन एंड जॉइंट्स, tissue and synovial fluid, synovial biopsy, synovial fluid examination, molecular test is here also important. Then pericarditis, pericardial aspirate for AFB smear, total lymphocyte count, differential count, biochemistry, culture, biopsy and molecular test. If cold abscess anywhere, you get the sample and process further in the same way. So there are various methods like various diagnostic tools, radiology like X-ray, CT, MRI, they are helpful in localizing the disease and guided biopsy and getting the sample. In the same way, ultrasound to localize fluid, to detail about lymph nodes and guided aspiration biopsy. Histopathology is important. Then molecular tests, as I told that gene expert and we will tell about the gene expert is a very sensitive test, and even less number of bacilli in the sample can be detected. And this will also tell about the level of I mean status of the rifampicin, whether it is resistant or it is sensitive. So tuberculin test in extrapulmonary can give you a suggestive evidence, supportive evidence. So this way you can see that the clinical suspicion, extrapulmonary tuberculosis में clinical suspicion बहुत important है. अगर suspicion है तो try to get the appropriate sample और उसमें smear, CBNAT, now it is endorsed by WHO and our national program for the diagnosis of extrapulmonary tuberculosis. I will tell you where it is more important, where it is less important. Culture is helpful, but it takes time, 2 to 3 weeks. Biopsy is important in few cases, depending on the at what place we are talking about the extrapulmonary tuberculosis. So blood test has no role. Like IGRA test, blood sample is not a sample for making diagnosis of this extrapulmonary tuberculosis. जो डायग्नोस्टिक वर्कअप आप करेंगे एक्स्ट्रा पल्मोनरी ट्यूबरकुलोसिस का, सभी मरीजों का एक तो HIV टेस्टिंग करवाना है, सभी मरीजों का चेस्ट एक्सरे कराना है टू सी वेदर कोएग्जिस्टिंग पल्मोनरी TB देयर आर नॉट. Appropriate specimens sent for expert MTB RIP as I talked, microbiology, smear and culture, histopathology, cytology, biochemistry, depending on the site of involvement. It is an algorithm for making the diagnostic approach in extrapulmonary tuberculosis. So, जो suspect case है, presumptive extrapulmonary TB का case है, उससे appropriate sample should be taken. अगर सैंपल अवेलेबल है या नहीं है, सपोज अवेलेबल है तो उसे CB नेट लगाएंगे, अगर ये नहीं है तो लिक्विड कल्चर लगाएंगे. सपोज CB नेट और लिक्विड कल्चर में MTB डिटेक्टेड आता है तो ये माइक्रोबायोलॉजिकली कंफर्म EPTB हो गया. और अगर मान लीजिए इन दोनों में निगेटिव आता है तो ये हाई क्लिनिकल सस्पिशन वाला केस है. इसमें आपको बाकी दूसरे डायग्नोस्टिक टूल्स अपनाने पड़ेंगे. अगर ये इसमें कंफर्म हो जाता तो इसको कहेंगे, हियर वी कॉल इट माइक्रोबायोलॉजिकली कंफर्म, हियर वी कॉल इट क्लिनिकली डायग्नोज EPTB. ओके. So what is the status of this MDR, gene expert test? In 2013, WHO did a systematic review of this gene expert test, and according to this report, systematic review, you can see for the lymph node TB, sensitivity is around 85% and specificity 92.5%. So you can say it is a good test for lymph node TB. Regarding CSF, it is around 80% CSF sensitive and 98.6% specific. Pleural TB, this test is not very much sensitive and it is not routinely recommended. Only it is 44% sensitive, but it is specific if you go for. In gastric lavage, it is sensitivity is good. You can see here 83.8% and 98.1% specific. If you are getting a case of lymph node, तो उसमें सैंपल क्या है, एक्सपर्ट MTB RIP should be used as an additional test to conventional smear microscopy, culture, cytology, FNEC. So it is a strong recommendation. जो इंडेक्स TB गाइडलाइन में इसको स्ट्रांगली रिकमेंड किया गया कि आप जिन एक्सपर्ट के लिए जाइए. मेनिंजल TB में कंडीशनल रिकमेंडेशन है, मे बी यूज एज एन एडजंक्ट टेस्ट. और नेगेटिव एक्सपर्ट MTB, जबकि अगर नेगेटिव आता है तो ये नहीं कहेंगे कि वो नहीं है, स्टिल मेनिंजल TB कैन बी देयर. सो अगर इसे पॉजिटिव आता देन इट इज़ वैल्यू, नहीं आता तो स्टिल यू में थिंक. द डिसीजन टू ट्रीट फॉर TB बेस्ड ऑन क्लिनिकल फीचर्स एंड CSF प्रोफाइल, ये जो एक्सपर्ट एरिया, एक्सपर्ट की राय लेकर के एंड क्लिनिकली इफ यू आर मेकिंग द डायग्नोसिस, गो फॉर ट्रीटमेंट. Regarding pleural, as I told that expert MTB is a very less sensitive test, so it is not strongly recommended, should not be routinely done. Regarding spinal TB and other forms of bone and joint TB, suspect TB when signs of joint infection with an insidious onset, imaging test, X-ray, MRI, CT scan can be done. You can take expert opinion of the orthopedic team who can assess the joint or and arthroscopy etc. may be helpful, and specimen should be subjected for microbiological confirmation. Regarding this spine tuberculosis, dorsal spine is the most commonly affected area, around 44%. It is in the स्पाइन, स्पाइन के अंदर देखेंगे सबसे ज़्यादा ये दिस डॉर्सल स्पाइन अफेक्ट होता है, फिर लंबर स्पाइन 26%, दो अदर एनी पोर्शन कैन बी. तो इसमें एक बैटसन प्लेक्सस ऑफ वेन्स होता है जिसके द्वारा ये बोन में पहुंच जाते हैं. ये हो सकता है पैराडिस्कल, सेंट्रल, इंटीरियर एंड पोस्टीरियर इन्वॉल्वमेंट में भी देयर. I will not go much detail. So CT scan can be helpful. MRI can be helpful. Here you can see the collapse of these two vertebrae and collection of the this pus is there. So now diagnosis of peritoneal TB, percutaneous sampling of ascitic fluid. So if ascites is there, you can take it out, and specimen should be sent for cytology, albumin, protein, ADA, microscopy for AFB, culture for MTB and other organisms, serum albumin acidic fluid ratio. अगर ये this less than 1.1 with a high protein, then it is it will be level as a exudative ascites, and it is a suggestive evidence of this peritoneal tuberculosis. AD अगर more than 39 units आ रहा है तो ये suggestive of abdominal TB. Ultrasound of abdomen is a very good test for this abdominal examination. So intra-abdominal fluid, free fluid you can see, loculated fluid you can see. You can delineate interloops ascites, mesenteric lymphadenopathy, bowel wall thickening, enlarged lymph nodes, central necrosis and peritoneal enhancement, peritoneal omental thickening. So ultrasound is very good test for workup of abdominal tuberculosis, peritoneal tuberculosis. USG guided FNAC, core biopsy, अगर कोई लीजन ऐसा है तो अल्ट्रासाउंड गाइडेड FNAC के लिए जा सकते हैं. CT MRI can be helpful. Laparoscopy in few cases, complicated cases can be proceeded, but it is not routinely recommended because it is a quite invasive test. Regarding lymph node TB, fine needle aspiration cytology, as I told, excision biopsy may be helpful. If it fails, FNAC में कुछ नहीं अगर कर पाते हैं तो excision biopsy के लिए जाएगा. Deep lymph nodes require radiologically guided sampling. So classical finding you can see here, and this histopathology. Cervical, you can see another case. This CT and MRI is helpful to delineate the lesions. Presumptive mediastinum में हम लोग CT कराते हैं, अक्सर देखते हैं, इसमें मिल सकता है आपको. एब्डोमेन में भी आपको मिल सकते हैं, इसे लिम्फ नोड्स के इन्वॉल्वमेंट और कैजिएशन यू कैन डिलिनिएट. डायग्नोस्टिक वर्कअप फॉर पेरिकार्डाइटिस. ट्यूबरकुलोस पेरिकार्डाइटिस आल्सो इज अ कॉमन थिंग जो मिलता है अक्सर. उसमें पेरिकार्डियल इफ्यूजन पेशेंट में प्रेजेंट विथ शॉर्टनेस ऑफ ब्रेथ विथ कॉन्स्टिट्यूशनल सिम्टम्स. Sometimes you may get a cardiac tamponade kind of presentation of this pericardial tuberculosis because of pericardial effusion. It squeezes the heart and there is a tamponade effect. So ECG and X-ray will be important. Echo is important. Echo may pinpoint the pericardial effusion and constrictive pericarditis if it is. CT is usually not recommended, but CT may give you a hint of the other associated lung condition about the lymph nodes, etc. So CT sometimes may be important. Diagnostic workup of urinary TB. So early morning urine sample is important. So 3 to 5 urine sample for AB, smear and culture for MTB should be taken. Microscopic and culture for non-microbacterial organism. Sterile pyuria, as I told, जैसे आपने पायोजेनिक कल्चर सेंसिटिविटी कराया, कल्चर निगेटिव आ गया, और अगर टीबी सस्पेक्ट कर रहे हैं तो टीबी में भी एबी स्मीयर तो सीधे आएगा नहीं, मतलब कंसेंट जो उसका सेंट्रीफ्यूज करके दैट सैंपल शुड बी टेस्टेड फॉर माइक्रोबायोलॉजिकल कंफर्मेशन. किडनी यूरेटर ब्लैडर पोर्शन अल्ट्रासाउंड में भी हेल्पफुल. CTMR, urography, sometimes renal function test may be important. Urethrocytoscopy, bladder biopsy when suspected malignancy and other tests to be ruled out. So this kind of test, if you are thinking urinary tuberculosis, you may go ahead for these tests and pinpoint the diagnosis in that case. Pleural TB, ये तो मतलब हम लोगों का रूटीन का काम है. तो प्लूरल ट्यूबिंग में बहुत ज़्यादा कुछ कहना नहीं है. परक्यूटेनियस एस्पिरेशन, ऑलवेज शुड डू डायग्नोस्टिक एस्पिरेशन. यूजुअली थेरेप्यूटिक, अगर मॉडरेट या ज़्यादा इफ्यूजन तब करते हैं, अदरवाइज थेरेप्यूटिक करते हैं. और देन CT स्कैन, थोरेकोस्कोपी इफ डायग्नोसिस इज अनक्लियर, लेकिन पहले हम शायद डायग्नोसिस इसी प्लूरल फ्लूइड से बना लेते हैं. प्लूरल बायोप्सी इज हेल्पफुल इन सम टाइम, अगर डायग्नोस्टिक डायलेमा हो तब. सेंड स्पेसिमेन फॉर AB स्मीयर कल्चर बायोकेमिस्ट्री. एक्सपर्ट MTB के बारे में बताया, बहुत सेंसिटिव नहीं है, करीब 40-45% सेंसिटिव, तो यू मे नॉट गो फॉर दिस. बायोकेमिकल टेस्ट, ग्लूकोज, प्रोटीन, ADA, LDH लेवल शुड बी सेंड, LDH शुड बी सेंड. एक्सुडेटिव इफ्यूजन है तो उसके एक जो ये लाइट्स क्राइटेरिया यू कैन सी हियर, प्लूरल फ्लूइड वर्सेस सीरम.
डॉक्टर कुशवाहा प्लीज, बहुत अच्छा पढ़ा रहे हैं लेकिन थोड़ा सा फास्ट होइए.
बस फ्यू स्लाइड्स more. सो कुटेनियस TB कभी कभी ये भी देखने को मिलती है. इसमें आप बायोप्सी कर लीजिए, स्किन बायोप्सी, हिस्टोलॉजी, स्टेनिंग और कल्चर के लिए. ये GIT का TB जो है कई बार हाथों में मिलता है, तो उसमें आप उसके लिए इलियो इंडोस्कोपी, कोलोनोस्कोपी, अपर GI इंडोस्कोपी, यू मे नीड समटाइम्स CTMR, इंट्रोग्राफी, इंट्रोक्लाइसिस and barium studies. Barium study is not routinely done nowadays, but sometimes it may require. Meningitis, tuberculosis meningitis is very important extrapulmonary presentation, you can see, and it is a lot of associated with lot of morbidity and mortality if not taken care early. सो अगर इसकी अर्ली डायग्नोसिस नहीं बनेगी, लेट डायग्नोसिस बनेगी, तो उसमें पेशेंट की मॉर्टलिटी हो सकती है, मॉर्बिडिटी हो सकती है. तो जैसे पेशेंट प्रेजेंट कर रहा है, हेडेक विथ अलॉन्ग विथ कॉन्स्टिट्यूशनल सिम्टम, हेडेक, लॉस ऑफ ग्रेजुअल लॉस ऑफ कॉन्शसनेस, समटाइम्स पेशेंट में प्रेजेंट विथ कोमा. तो अगर कोमा में जाएगा तो उसकी प्रोग्नोसिस उतना अच्छा नहीं रहेगा, तो अर्ली पिकअप करना ज़रूरी है. सो इफ़ इन सस्पेक्टेड केसेज नेक रिजिडिटी हो सकता है उनमें, ठीक है. तो अगर इनमें ये सब चीज़ मिल रहा है तो यू शुड गो फॉर लंबर पंक्चर एंड गेट CSF, एंड CSF 6 ml CSF शुड बी टेकन, बी कलेक्टेड फॉर इन एडल्ट्स एंड 2-3 ml इन चिल्ड्रेन, एंड इट शुड बी सेंड फॉर MTB, आई मीन जीन एक्सपर्ट टेस्ट, AB स्मीयर कल्चर एंड बायोकेमिस्ट्री. एंड CSF लिम्फोसिटिक प्रिडोमिनेंट होता है, ठीक है. इसमें सीरम ग्लूकोज भी डाउन मिलेगा, लेकिन जैसे अगर पायोजेनिक मेनिंजाइटिस है तो उसमें तो 0 भी मिल सकता है, बट इसमें मतलब इन द ट्यून ऑफ 30s आपको मिलेगा. तो अदर टेस्ट जैसे बाकी और को रूल आउट करने के लिए, जैसे निसीरिया मेनिंजाइटिस, वो सब टेस्ट आपको करवाना है. in brain you may get tuberculoma, it is miliary tuberculosis. Here you can see the case is same, presenting at two places. Regarding the female urogenital TB, it is a very important area. So शुरू में जैसे कई बार इनफर्टिलिटी के केसेस जो हैं, फीमेल इनफर्टिलिटी के केसेस इंडिया में करीब 20 से 25% इनफर्टिलिटी, फीमेल इनफर्टिलिटी इज बिकॉज ऑफ urogenital tuberculosis. So hysterosalpingogram is important test, then pelvic ultrasound as a part of initial assessment. CT-MRI may be important to characterize lesions and plan surgical intervention in selected patients. FDG PET may be helpful to delineate more, getting more information about the presence of tubo-ovarian mass lesions. Laparoscopy in some cases may be important, and endometrial aspirate is important and should be subjected for AB smear culture, etc. A few words about this ocular tuberculosis. Ocular imaging is important. Ophthalmic examination, advanced ophthalmic
कितने स्लाइड है अब?
बहुत ज़्यादा नहीं, थोड़े होंगे. टाइम है कि नहीं?
टाइम तो बिल्कुल 10 मिनट्स ज़्यादा हो गया.
10 से ज़्यादा, 20 मिला था.
30 मिनट हो गए.
अच्छा, चलिए
30 मिनट हो गए.
एक टाइमर लगा देना.
फास्ट कर दीजिए.
एनीवे तो ठीक है, ऑप्थेल्मिक एक्सपर्ट को लीजिए, उनके पास काफ़ी रेफर कर दिए, दे हैव एडवांस टेस्ट एंड गेट इट। समटाइम्स विट्रियस सैंपल या वो, हाँ, उसका बायोप्सी या करवाना पड़ सकता है उनको। ये एग्जांपल्स हैं कुछ, इनमें नहीं ज़्यादा बताएंगे आपको, ठीक है। रेजिमेन और ड्यूरेशन, रेजिमेन लगभग सेम है उसका, ठीक है। ट्रीटमेंट ड्यूरेशन के बारे में भी आपको डिटेल में बताते हैं। लिम्नोड टीबी में 6 महीने हैं, दिस प्लूरल टीबी, लिम्नोड टीबी, प्लूरल टीबी, पेरिकार्डाइटिस, एब्डोमिनल टीबी, इनका 6 महीने ड्यूरेशन है टोटल। और रेजिमेन आप देख रहे हैं 4 ड्रग फॉलोड बाई 3 ड्रग, ओके। यूरोजेनाइटल टीबी में इनका भी 6 महीने ड्यूरेशन है, सेम रेजिमेन। Then ear, nose, throat and cutaneous. It is all 6 months. Here, in ocular case, 6 to 9 months should be treated, and this regimen is same, but duration is more. This tuberculosis meningitis, 12 to 24, I mean extension up to maximum 12 to 18 months sometimes. CNS tuberculosis also, 12 to 18 months should be treated. Spinal and other forms in the same way. ट्रीटमेंट इज एक्सटेंडेड। जहाँ 12 से 18 महीने उनमें करेंगे, जो अगर लेट रिस्पॉन्डर है तो उसमें आप करते हैं। तो ये जो रेजिमेंट डोजेज हैं पर mg पर kg के हिसाब से छोड़ दे रहे हैं सर, डिफरेंट FTC वेट बैंड। और ये मैंने आपको बता दिया कि 6 महीने इनमें है, बाकी इनमें एक्सटेंशन की ज़रूरत है। और कार्टिकोस्टेरॉइड जैसे स्पेशल केसेज में न्यूरोलॉजिकल ट्यूबरक्लोसिस में इम्पॉर्टेंट है, एंड फॉलो ऑर्गन्स की जो ट्यूबरक्लोसिस सीवियर फॉर्म्स में कार्टिकोस्टेरॉइड्स आर आल्सो इंडिकेटेड। एंड आई विल नॉट गोइंग इन डिटेल। सो सर्जरी इन फ्यू केसेज, जैसे ऑक्यूलर में बताया मैंने, मेनिंजाइटिस में जैसे हाइड्रोसिफेलस हो रहा है, तो ये फाइनल अर्ली एंड एक्यूरेट डायग्नोसिस इज इम्पॉर्टेंट। एज आई टोल्ड, try to get bacteriological confirmation if possible, identify concurrent active TB, avoid unnecessary invasive and costly tests, prefer FNAC tissue based diagnosis. Bacteriological tests may be helpful in some cases. Thank you.
चलिए, थैंक यू डॉक्टर कुशवाहा फॉर वेरी नाइस एंड वेरी डिटेल प्रेजेंटेशन।
कुशवाहा मैं एक मिनट, मैं ये बोल, I have been part of this guideline. And what I wanted to emphasize, this was very evidence-based. This guideline was made in April, and now in collaboration, every question was asked. Just search there for us. What is role of this? This is very evidence-based guideline for extrapulmonary tuberculosis. So try to follow it. It's not the individuals, not that I think like this, I think like न्यूरो में PGI चंडीगढ़ से एक सेंटेंस बोला था, इंडिविजुअल में भी, इंडिविजुअल में कुछ भी कर सकता हूँ। I develop a guideline that it must be a वाले हम लोग थे, हमने कहा ये तो हो that was developed. So to my understanding, the very comprehensive guideline for extrapulmonary. Thank you.
थैंक यू। अच्छा लगा कि वी फ्रॉम दी डॉक्टर एस तो मिक्स करके बहुत अच्छा लगा था।
I request Senior Consultant, Pulmonary Medicine Hospital, Dr. Ramnarayan Rao, Senior Consultant Hospital, and we also welcome Dr. Villa session. Thank you so much, ma'am.
Okay, good afternoon, everyone.
Good afternoon. It is my privilege to introduce my head of services, sequencing for as a TB person for the last 20 odd years. She has been working in TB and clinical microbiology and virology ever since she's been in the institute, which is about 40 years odd. She is noted among the top 2% eminent scientists and has received several national and international awards and has more than 50 publications and has been cited more than 6,000 times. A very warm welcome to Professor Amita Jain.
Thank you.
And we wish to hear her golden words.
Thank you very kind words. About molecular tests which we used for diagnosis of drug-resistant TB. So without any this thing, because what I see here are mainly resident doctors and the faculty. So I'm sure you are aware with lot number of things. So I'll try to maybe skip few slides and go ahead with just the basics. So just I acknowledge everyone with whom I work at TB lab, and Dr. Parul has helped me make some of these slides. What is the current role of laboratory in management of tuberculosis? So the test we offer at the laboratory help you either for the detection of the disease. Is it active TB or latent TB or no TB? This helps us in deciding that should we treat this TB, should we not treat this TB. Then the tests also help you to decide, is it a drug resistant or drug sensitive TB? So that helps us decide which regimen are we going to use for our patient. Then when we are putting our patient on treatment, we need to follow up these patients and see that how they are responding. So assessment of their response to treatment has to be done through laboratory tests so that we can assess midterm, midway, during the treatment. It's a long treatment, so it's very, very important. Epidemiological studies and research, which may not be of interest to a lot of people. What I'm going to talk here right now is the detection of drug resistance and assessing response to treatment very, very briefly. These are the various references which I have used to make this presentation. They all are free downloads available on websites. You can download that. If you look at this one flow diagram, it's very comprehensive. It's very complicated. It looks very, very big, but it's very clear. If you look at TB diagnosis, upfront test which we offer to all our patients is NAT, Gene Expert. It can be any form of TB, TB with HIV, new case, old case, whatever it is. The first test which we offer is NAT. And once we get the NAT results, they usually come as TB, yes or no, rifampicin resistance, yes or no. So these are the two, and you all know that. So these are the two information which come to us once we offer the NAT. With NAT, we also offer AFB smear examination, which is actually very, very cost-effective test, and most of the time is able to give us a lot of information. So after doing that, what I'm going to talk here is about the arm on which we get rifampicin detection. So this right arm is the arm of our interest, not what we are going to talk here. So if you look at this, which you may be able to read or maybe not, it is if we detect rifampicin resistance, every patient gets a reflex testing for first line LPA, second line LPA, LC-DST, liquid culture DST for pyrazinamide, bedaquiline, clofazimine, moxylinezolid, and delamnide. I'm not going to talk about LC-DST today. We'll be only focusing to molecular assays. So two assays which we are going to, molecular assays, every rifampicin resistant TB is going to get two molecular assays reflexly, which is first line and second line LPA. This is what NTEP says. Nice thing is that at KGMU we follow this pattern. We can go beyond that. Nobody is stopping that. But we should not go less than that. So anything which we are doing should be minimal this. We can add anything. Nobody is stopping us from that. Once we do that, I'm not talking about this arm, we don't have much choice. What we have, tests for diagnosis of TB, unfortunately the available tests for TB diagnosis, which we call microbiological confirmation of TB, is very small. It's a very small box with very, very few tests. For diagnosing TB and managing TB, we have look for AFB, look for Gene Expert, do the TrueNAT. TrueNAT is nothing but just a sibling of Gene Expert. For managing looking at the response to the treatment, we do AFB detection and culture positivity. No NAT for monitoring response to TB. Very frequently we receive a specimen. Patient is on treatment for 3 months. Gene Expert kar dijiye. Gene Expert will only confuse you. If it is positive, what does it tell you? Bacterial DNA in the specimen. Dead bacillized DNA remain in the CSF, sputum, any sample for very long time, usually more than 4 weeks. So no help, it's going to misguide you. Number 2, this test only tells you about rifampicin resistance, not beyond that. So drug resistance development, new drug resistant development takes time to develop. So you should be testing for a larger panel of tests. That's why we go with culture and drug susceptibility as it is positive. Culture detects live bacilli. So no expert for follow-up or management. Then coming to the test for detection of drug resistance. Again, we have a very small kitty here. We have Gene Expert, which tells us rifampicin resistant. Then there is a new form of expert which has come in the market, Expert XDR. Program doesn't talk about it, but it's easily available in the market. So maybe at times you get to look at the reports of Expert XDR. I'll briefly tell you what does this test tell you. Line probe assay, first and second line, and then the culture methods, which we are not handling today. Whole genome sequencing are the newer platforms which are coming in market. And not less than twice a week, I get to see such reports. These are very dependable reports. These are all commercial platforms which are available. The cost is something we need to discuss, but program has still not implemented this. Program is trying gene sequencing for detection of drug resistance. Maybe very soon we'll have such test available. So this is whole panel of tests. This is all we have. We don't have many, this thing in our armamentarium. Very few arms, very few. Gene Expert, we all know it's a fully automated test. Same day you get the result. It looks very simple. There's a cartridge, you put your sample, put the cartridge in the machine, take the report after 2 hours. That's very simple. But trust me, it's a very complex mix of technology, which talks about large number of probes. Probes are also special. These are molecular beacon probes, which are specially designed, and they are able to detect mutations in drug resistance determining region of RPOB gene. Drug resistance determining region of RPOB gene, not the whole gene. So this I'm not telling, but as you can see with these pink probes, they can actually map the whole drug resistance determining region, and any mutation in these is detected by these mutant probes. So this is a very, very lot number of 10 probes are totally used in this machine. Then there is a newer version of this which has come, is available as RIF Ultra, MTB RIF Ultra. This is an advanced form of Gene Expert. Again, program has still not implemented it, but it is supposedly more sensitive, 10 times more sensitive, 1 log. So if the older version can detect 100 bacilli, this can detect even 10 bacilli. So this is 1 log easier, because they have added more probes here. Then the XDR Expert. XDR Expert does what? It picks up resistance for INH, which was not in the first one, fluoroquinolone, second line injectable, and ethionamide. The problem with second line injectable detection is it's obsolete now. None of the regimen tells you to use second line injectable. This cost quite a lot. It's about 3,000-4,000 rupees test, and second line injectable information is not used anymore. So probably that's the reason program has not implemented this test. I'm skipping this. And if you look at these are the targets, I'm not going into the details, sensitivity and specificity. If you look at versus phenotypic test, it's fairly sensitive, except ethionamide. It's fairly sensitive and fairly specific too. So this is a good test, but again the problem is that we don't want the information on second line injectables anymore, so this is a redundant information. TrueNat is a sibling. It's a make in India test, made in India test, and costs 1/3 of Gene Expert. So government is in the mode promoting it. It's a very small machine. It's just this much. It's like your lunch box here, which can be taken in the field easily, and you don't need even electricity supply. So it's a very good POC, point of test, which is being used. And while the Gene Expert cartridge cost around 2,000, this cost around 700 rupees. So that's the price difference. Coming to the line probe assay, this is a complicated test. It's very complicated to run the test also. It's a reverse hybridization. I'm not going into the technology because I understand the people from laboratory here are very few, but this is designed to identify, is it MTB or not? Is it MTB complex or not? And it detects mutations associated with drug resistance. The first line strip kit detects resistance to INH and rifampicin. The second line ones detect resistance to, additional resistance to fluoroquinolone and second line injectables. And it also tells you, is it high level or low level moxifloxacin resistant. So that's a very good information which you get, because if it's low level moxifloxacin resistance, you can start your patient on short duration bedaquiline treatment. So this is an additional information you get. Again, the problem here is that, do you really want the information on second line injectable resistance? I don't think it's clinically any more relevant. But another problem with this test is, this can only be applied on the specimen which are AFB positive. If they are AFB negative, you cannot apply it. So this test is applicable either on the culture isolates or on the AFB positive samples. It's not available. So most of the extrapulmonary samples which we get are not suitable for application here. So these were some technical details of this test, which I think may not be of use for anyone, but if you want, we can discuss it later sometime. This is how these strips look. This is one strip, and this is how we read. We put the strip, there are bands which develop in the end of the test. We put this strip against a card which has this information, and we can read the test appear or not appeared. There are two types of bands here. Few bands are wild type, which we said WT1, WT33. So all the sensitive isolates should develop all the WT bands. So WT, if that is missing, that means there is a resistance. So WT should appear always. That is wild type. मैंने wild type से ये match कर रहा है. If even one is missing, then it is a mutant and you'll say it's resistant. You'll not use that drug over here. Then there are some probes which are mutation probes. So these mutation probes detect those mutations which are known to be frequently associated with drug resistance. So if wild type is missing either, or mutation type is appearing, normally mutation type should be all absent, wild type should be all present. That's a normal wild type strain sensitive to that particular drug. But if wild type misses and mutant type appears, or even if wild type is not missing and mutant type appears, even if mutant type doesn't appear and wild type is missing, so if the pattern changes at all, that's a variety of a mutant strain, and that will be called a resistant strain. So here we look for RPOB gene, which tells us rifampicin resistant. Then we talk about CAT-G, which tells us high level resistance to INH. And then INH-A, which tells us low level resistance to INH, along with ethionamide and prothionamide. So ethionamide, prothionamide and INH, this is covered by INH-A. CAT-G is high level and rifampicin B. So this is how this test is read. So this is the coverage, you can forget it. So when we write reports you get, sometimes you say resistance not detected. That means all the mutant types were absent, all the wild types appeared. That means this strain is as similar to the wild type, and we call no resistance detected, you can give that drug. Sometimes you get to read resistance inferred. When the mutant type has not appeared, but wild type has, mutant type covers very few mutations, 2 to 4 mutations for each drug which are common. But if wild type is missing, that means there is a mutation in that area which is different for the mutants you are looking for. That means resistance inferred. I do not know which mutation is there, but I know there is a mutation, so there are very, very high chances that this drug will not work. But if I pick up a mutant probe, there's a mutation, then we say resistance detected. In both the situation, when we say inferred or detected, we will not use that drug. But if we say not detected, that's the safe drug you can use. So this is the interpretation table, which in large talks about each drug. Basically is the same thing which I have said right now. Inferred, detected, not detected. If not detected only, then you'll give that drug. Inferred and detected, you'll not give that drug. So this is for different drugs we have talked about. Then last coming to genetic sequencing. How does drug resistance appear in Mycobacterium tuberculosis? Through the mutations. So there is a mutation, the strain becomes resistant. This mutation should occur in some genes which are known to cause resistance. Mutated genes are known to cause resistance to that particular drug. So based on that, what we do in sequencing, we look for these mutations. There are two types of models which are used. One is targeted, the other is whole genome. Targeted means suppose we have 15 drugs. For these 15 drugs, let's assume we have identified some number of 20 genes. We will amplify that small drug resistance determining region of those 20 genes, and we will do the sequencing. Any mutation detected, there's whole bioinformatic tool which comes with the platforms. There's a program available. You feed your data, the result comes. So they tell you that this mutation detected, resistance or not resistant. In contrast, the whole genome sequencing takes long time. That generate lot of data, but it is not easy. It gives you a lot of additional information too, but again, the cost becomes more and the analysis becomes time consuming and cumbersome. So there are some platform, one which is available for both. They're kits, in fact, they're different kits. Some are available for both, some are available for one type. So they can be targeted or whole genome. For most of the time for TB diagnosis, reports are coming from Illumina platform, MySec, and that is a targeted sequencing. So this is about NGS. NGS tells us additionally, other than the drug resistance, which is for many drugs, 15 anti-tubercular agents which are in clinical use, it tells you resistance to each one of them. Then it tells you about the strain lineage also. Strain lineage, how it is important for us? It just tells us the transmission pattern, where from your strain has come. It has no clinical value, but if you want to follow the transmission of the strains, you can use this information. And other than that, it does not give you anything. Concerns with that. What are the concerns? Cost. Concern still. But as things are progressing, I feel maybe within a year or two, it will become really cost effective and we will be able to use it. Then we have to integrate it in the laboratory workflow. The laboratories which are in the program and otherwise also, they are suitable for basically culture-based phenotypic testing and very basic molecular testing. So we have to develop our laboratories for NGS, which will be a very heavy cost. We have to understand the computational expertise. We do not understand computational part very well. For analysis, we need some experts which can do the analysis well, or at least understand whatever the output machine gives. For that, manpower is not easily available. So regarding that, there is a lot of work going on, and let's see when program can implement that. So there are 3 platforms which are commercially available for TB sequencing. Illumina MySec is actually the most preferred one. Then there's a PyroMark 48 and QIAGEN. QIAGEN is coming up. Then Oxford Nanopore, they have a platform which seems like cost effective. It's a good quality long read data which is produced, but again, there's no kit yet available for that use. So this was just the flow and the difference in the whole genome and the targeted NGS approach. I basically told you everything here. So with this, thank you very much. And what we need today is actually a good test, which can be a point of care test, where we can pick up every possible TB case. Thank you very much. And if there are any questions, and if the people allow, I can take it. Thank you very much. So maybe
any
other time
questions
when
from
we
the
meet.
audience first? Any questions?
So thank you very much. Thank you for your patience.
मैम आपने बहुत अच्छा मॉलिक्यूलर टेस्टिंग के डिटेल्स बताई, और अभी तक जो हमारा RNTCP प्रोग्राम था, इसमें ये टेस्ट नहीं था, जिसकी वजह से बहुत सारे केसेस मिस हो जाते थे.
कौन सा एक्सपर्ट?
हाँ, ये मैं जो मॉलिक्यूलर टेस्ट जो जीन एक्सपर्ट,
जी,
तो उससे बहुत सारे जो हम लोग करते थे, जो स्मीयर माइक्रोस्कोपी करते थे, काफ़ी केसेस मिस होते थे. इसके आने से बहुत सारे केसेस में देखा गया है कि स्मीयर नेगेटिव है, लेकिन जब इसको भेजते हैं तो पॉजिटिव आता है, और इससे एक रेजिस्टेंट केसेस जो हैं उसमें भी हमें जो है ट्रीट करने में हेल्प मिलती है, डायग्नोज करने में हेल्प मिलती है। मैडम थैंक यू वेरी मच, बहुत अच्छा आपका डेलिब्रेशन था, थैंक यू।
Thank you very much. Agreed with all the points.
Thank you, ma'am. I would request Rajendra Prasad sir and Ved Prakash sir to please felicitate Professor Amita ma'am, a speaker for this session. Dr. Vipula ma'am, Professor KGMU. Sir. Dr. Ramnarayan Rawat sir. Photo please, thank you. For the next session, I'd like to invite consultant Pulpur. Dr. Ashok Yadav sir. Dr. Rajkumar Kalyan sir. And Dr. Sheetal Verma ma'am.
Dr. He will talk on tuberculosis. He is the former director of VP Chest Institute, University, former director of UP RIMS, Sefai, former head of the Department Respiratory Medicine, KGMU Lucknow, former head Department of Pulmonary Medicine, Era Medical College, Lucknow. He has very credits in his as awardee, like Sir BC Roy awardee, ex-president of ICS, NCCP, TAI, NA, NCAI, NTF National Vice Chair, NTEP, ardent academicians, and one of the leading researchers in tuberculosis. More than 200 publications and over 2,500 citations. So, welcome, sir. Okay, sir.
ultimately has been dreamt by me very long back. And I am happy that these two departments are working. I once again thank you, Dr. Ved, for remembering me. मैं कभी कभी कहता हूँ वेद मुझे जो है वो बिल्कुल बांध लेता है, जाने नहीं देता है, कहाँ कहीं बैठा है नहीं बैठा है, तो बीच बीच में कभी छोड़ दिया करो मुझे भी. So what I will do in next maybe, although time is 20 minutes, but I'll try to reduce the time and I'll skip some of the slides in between because unfortunately I did not get time to see these slides before because there was a convocation in ERA. I was little busy. I came from that place. And you know, these are the photos you just skip. And this is a new proverb I used to quote now. Kuswaha is looking very happy. Better than 1,000 days of diligent study is one day with great teacher. Why I am saying, I now use these quotes for UG and PG students. Because you know, there are, आजकल बंकिंग होती है बहुत ज़्यादा, हमारे ज़माने में तो शायद नहीं होती थी. So for that, you know, this proverb is very right. कोई भी अब मान लिया राजीव गर्ग पढ़ाने आए हैं, कुशवाहा साहब ने अभी पढ़ाया, तो पता नहीं कितनी किताबें इन्होंने पढ़ाई. So please, especially for PG students, whenever the class must attend that. You learn something. What I am trying to say. Then I always pay my tribute to my own mentor because I believe whatever I am today, it is because of him. He was a great mentor, I must say, as far as tuberculosis is concerned. And he was the one who induced us for non-tubercular disease also. That is why you see this Department of Pulmonary Medicine, Critical Care Medicine. So tribute to him. And another my mentor is international, that is John Crafton, जिसकी हम सब किताबें पढ़ते हैं. Or my agenda today for next 15 minutes, little update in epidemiology of drug-resistant TB, although Bajpayee has covered it, update in treatment of tuberculosis, and if time will permit, something what is going to be future of drug-resistant TB management. Epidemiology, if we say that, you know that you have got many types of a drug resistance, you know, need not to define. Monoresistance, polyresistance, MDR-TB, rifampicin resistance, pre-XDR TB. Pre-XDR means MDR plus fluoroquinolone resistance, and XDR-TB means pre-XDR plus resistance to one of the group A drug. That is how it is latest defined. And if you see that MDR-TB globally, this is the latest report available in primary around 3%, and when you treat these patients, it goes to 17-18%. It means message is very clear: when you treat these patients, and especially you treat ineffectively, then the drug resistance rise. Around 0.5 million globally, and in India also same figure, about 2.5 and 13, and it is estimated that last year about 119,000 MDR-TB existed. And this is the latest survey which was published by government, done by Government of India, and that says similar figure. Primary about 2.8% and acquired around 11%. Though all the data are literally the same. So we are around that. And Amita was sitting, this is one of the paper we reported from KGMC with Amita about the pre-XDR and XDR-TB way back in 2010 when people hardly had any talk of pre-XDR and XDR-TB. What is disturbing, the next two slides, you find it's very disturbing. This slide says, this paper was published in 2017, that MDR-TB will likely to rise, especially in India and some of the other developing countries. And what the other point they are saying, actually you can understand, if the drug resistance will rise, अभी तो हम बात करते हैं acquired drug resistance की. Then the primary drug resistance will increase. We see many medical students. When I was in Patel Chess, I see lot of medical students who suffered from MDR-TB because they got infected from the patient. So that is why our duty is to, what I am trying to convey with this message, treat tuberculosis very effectively. Source of MDR and XDR TB is a sensitive TB. So especially for youngsters sitting, that's a very great message I always convey. How to treat DRTB? You know, we have got many types of drugs. I'll not go into many details, but I'll just give you the inkling. This is a drug-resistant PMDT management, although WHO published first and then India published. Luckily, I have been part of these developments in India. And we have got mono, poly, and then MDR. For MDR, we have a shorter regimen, we have a longer regimen. This is what we today exist. MDR and XDR both. And you know, initially when I was, say, teacher, still I'm teacher, then the INH resistance has similar regimen like category 1. But now we have a guideline that you have to replace INH with levofloxacin. That is one. And there are many rules do exist. Sometimes treatment has to be extended. Sometimes it needs replacement of the drug. That I will not go. But one thing is very clear. Now we have got regimen for INH mono resistance. It is common in India. And then MDR TB, as I said that I will take little less time so that I will be skipping slides. How to treat? Now, when I was a student, I was teacher way back in KGMC, we used to treat lot of MDR TB. I think many of the students of that time, they are sitting here. Rajiv Garg, Kuswaha, including so many. And now they have become stalwarts. I'm happy. And so what I'm trying to say, usually we have only one type of a treatment. Then 2016, we have a shorter MDR regimen. Actually, the shorter regimen started from Bangladesh trial. Bangladesh का नाम जब आता है तो लोग जरा अच्छी निगाहों से नहीं सुनते हैं. But this trial was started from Bangladesh. Ultimately, it was retested, and then finally it was approved by WHO 2016. And then we have a longer oral regimen for MDR and XDR both. And what is the shorter MDR regimen? Shorter MDR regimen means initially it was injectable, but now all the injections have been removed. Now it is an oral treatment. So here you see in this regimen, you see that there is a kanamycin. अच्छा ये है भाई, चलता है क्या? चलता है? कहाँ से चल रहा? अच्छा ये कहाँ था? कौन सा? अच्छा ये सुन. तो आप देखें ना यहाँ इसमें kanamycin भी है. तो shorter regimen, intensive phase about 7 drugs, then continuation phase 4 drugs. Initially it contained injection. The kanamycin was replaced later on with amikacin, and these injections were replaced with the oral regimen. That is, injection was replaced with bedaquiline. And sorry, ये regimen sorry कहाँ गया? नीचे वाला regimen है ये, देखे ना नीचे वाला है ये shorter all oral bedaquiline containing regimen. And one thing you have to understand, Dr. Surkant was referring in the inauguration that the difficult to treat TB clinic, most of the states are running it. And what we have experienced, I usually attend those clinics at the national and at the state level also. Many other states do it. So people go, anything which comes first, they go for first for that. So, but the shorter regimen, one should remember, is not for all rifampicin or MDR TB. You can understand simply it's for new cases where no resistance, like no fluoroquinolone resistance, which is very common in India, about 30%. No other drug, then it is a regimen, and it's a package. You cannot replace drug here. Once you feel that somebody is not tolerating drug, somebody has developed resistance to this, so this is not useful for, in one of the study done in Mumbai, that hardly 10-15% of the patients of MDR TB will be fit to be used shorter regimen. But unfortunately, this is being used for vanilla because reason is only one. Madam is sitting, we say that gene expert 90 minutes. I have tested it when I was in Patel Chest. 90 minutes में मेरे पास report phone आ जाता था. But the government setup में क्या हो रहा? 5 दिन, 7 दिन. हाँ, LPA. So because of these reasons, they say if you find MDR TB and you should do LPA1 and 2 to exclude other drug resistance. Ideally, it should be available within 3-4 days' time. But it's taking sometimes weeks, sometimes months. That is why, and you can understand, if you are using this shorter regimen in having additional drug resistance, you will be destroying those drugs. So that may be the reason, one reason. So that is the shorter regimen. And then then you have longer treatment. Today it is known as longer oral treatment because it's all oral. No injections in TB today unless somebody is very specific, somebody has developed drug intolerance, somebody is not tolerating, then you think of using. Otherwise, routinely injections are not used. So, longer regimen is for MDR, pre-XDR, regimen. And then, usually there are 3 groups of drug, A, B, C. This is very famous chart. These are the new drugs. Again, clofazimine is a repurposed drug. Linezolid is again repurposed drug. And bedaquiline and levofloxacin is again old drug. It is again a repurposed drug. So group 1, 2 and 3. I would like to make a very clear emphasis on the minds of young doctors. These grouping have been made based on their efficacy. That is number 1. It means group A drug is the most efficacious. Based on the mortality in the treatment, based on the adverse, so many things are taken together and this grouping has been done. And in this grouping, how we decide WHO says in the intensive phase you have 4 drugs, and in continuation phase you should have 3 drugs. But India government has decided based on our local situation that we should start with 5 drugs, and in a continuation phase we will have 4 drugs. That is the little WHO guideline. And this is the regimen, bedaquiline, minimum of 6 months, even now longer can be given, linezolid, levofloxacin, clofazimine and cyclosporine. This is one regimen throughout. Only the bedaquiline is used for 6 months, or sometimes in a situation where other drugs are not available, then you can use bedaquiline for longer duration. This is the standard all oral longer regimen. It has also got, suppose some drug you are not able to use from group 1 and 2, so then it should be replaced, and sequence of replacement has been worked out for India. For India, it is again different than WHO, little different. Is delaminid, amikacin, pyrazinamide, ethionamide, ethambutol, imipenem, amoxicillin. These are the sequencing people have given. If you require to be replaced 1 or 2 drugs, then there is a definite rule. If you are interested, you can go. I will not spend much time. And doses are also fixed. मैं अक्सर डॉक्टरों से कहता हूँ, हमारे एक एरा के भी पीजी बैठे हुए हैं बहुत डांट लगती थी कि दिमाग मत लगाओ अपना, टीबी में दिमाग मत लगाओ, और जगह लगाओ। क्या डॉक्टरों की परेशानी क्या है? बहुत दिमाग लगाते हैं, अपनी डोज, अपना ड्यूरेशन, अपनी दवाएं। So those things will not work. Yes, you can do that in maybe very small percentage of cases. Not in large percentage of cases, you have to stick to the guidelines. We still do that. हम भी अलग करते हैं कभी कभी, लेकिन not large number. That's a very clear message. तो doses are fixed. अभी मैं रोज पर्चे देखता हूँ, आई एम सॉरी, डॉक्टर सालवानी साहब से मैं बात कर रहा था, लिखा है वेट 64 किलो, रिफेम्पिसिन क्या लिखा है 450। ये कहाँ की डोज थी? किसने पढ़ाया? हम लोग तो साल जिंदगी भर पढ़ाए भाई, अगर वेट मोर देन 50 है तो मतलब 600 लिखो। अब तो रिफेम्पिसिन की डोज 1500 तक जा रही है, 900 तक जाए। तो व्हाट आई एम ट्राइंग टू से, please use these drugs in effective doses. That's another message. In some of the cases, you may think of surgery. ये भी है drug resistance में. And then we have new, like you know, next trial is very famous, what you call as BPAL. It is being done in UP also, in some of the centers. What is the beauty of BPAL is, it's only 3 drugs. Bedaquiline, pretomanid, and linezolid. 2 new drugs and 1 repurposed drug. And for 6 months, for all difficult MDR and XDR TB, in study protocol, they found it is 90% effective. So, actually, Ved gave me topic towards, are we moving towards universal regimen? So I'm moving towards that, maybe 2-3 slides more. So this is another regimen which is being used and probably used in India. Then maybe 2-3 minutes. What is the future? I have another 2 minutes with me. So future क्या होने जा रहा है? जो वेद ने हमको टॉपिक दिया है, तो जो फ्यूचर में क्या है, you must understand in last 20 years, new drugs, new studies being in line. We have GeneX study where we have tested the various dose of linezolid because it is very toxic drug. Then TB practical study, simply are moving towards, and then you have got latest guideline of drug-resistant TB last year, 2022, with all those studies. And they say that shorter regimen they have okayed, longer regimen they have okayed, and they are trying to reduce the duration, say like BPAL or BPAL-M, another regimen. So what is my is that I'll not go into details of these new guidelines. Still it is not being practiced in India. This is just government of India is taking a call on it, and probably in future it will be decided. I wrote an editorial way back in 2020, I believe, in Indian Journal of Chest Disease. Are we moving towards development of universal drug regimen? I say yes. My hunch is yes. Another editorial I wrote in Indian Journal, can pan-TB shorter regimen be a promising? Yes. You see, we are moving towards that. What we are moving towards, which direction? Number of drugs are being reduced. Duration is being reduced. And another thing what we are going to have, probably we will be having one regimen which can treat all sorts of tuberculosis. That is the future thinking in tuberculosis. I hope in my lifetime this will happen. I am pretty sure that this will happen, because if you read it, we keep on reading, and this will happen, and that is so what is universal regimen? अभी मैंने अपने इनाग्रल भाषण में बता रहा था कि ट्रंकेट स्टडी हुई आई है 7 दिन पहले, जो 2 महीने में ड्रग सेंसिटिव ट्यूबरकुलोसिस का इलाज निकलने वाला है. So you see that we are moving towards that. और ट्रंकेट में भी यही बीटा कुलिन और लाइनोजोलिट मिला के, तो कुल दवाएं यही रहेंगी। और उसको आप, my dream is that we may treat drug sensitive TB, although my topic is not, for 2 months, MDR for 6 months maybe, and XDR for 9 months. That is what is probably next 5 line. Before I should finish, I would like to show you a case. ये मैंने केस अभी मैंने इसको देखा है, एंड आई वुड लाइक टू स्पेशली जो यंग माइंड बैठे इनको बताना चाहता हूँ। क्या बताना चाहता हूँ वो वेद तुम भी देखो बहुत गौर से। मैं कभी कभी कहता हूँ जांचों का इलाज मत करो, मरीज का इलाज करो। ये मेरा बहुत पुराना डायलॉग है कि नहीं है? मरीज को पूरी तरह से देखो। दिस पेशेंट, यू नो, 16-year-old guy who has recurrent throat pain, hemoptysis, epistaxis, ये हुआ इसको। समझ गए भैया? कुशवाहा साहब देखो इसको क्या हुई, हिमोप्टिसिस। इंडिया में हिमोप्टिसिस तो बिल्कुल लोग समझते हैं इट इज सिनोनिमस फॉर ट्यूबरकुलोसिस। दिस इज दैट इज रॉन्ग। 12 मार्च को इसका जीन एक्सपर्ट हुआ गवर्नमेंट से। हिज फादर वाज एम्प्लॉय इन वन ऑफ द टीबी सेंटर। जीन एक्सपर्ट में क्या रिपोर्ट थी? एमटीबी डिटेक्टेड लो विद रिफैम्पिसिन रेजिस्टेंस, ये रिपोर्ट थी। वहाँ के डॉक्टर ने बिना कुछ सोचे समझे उसको एमडीआर ऑल ओरल लॉन्गर रेजिमेंट पर रख दिया। ठीक भी रख दिया एक तरह से। हुआ क्या उसके बाद इसको हुआ है कि आफ्टर 20 days of taking these drugs, body ache, joint pain, severe headache, pain abdomen, nausea, vomiting, tingling, numbness, lower, ये बच्चा पागल हो गया। तो भी मैं उसके पेरेंट्स के वर्ड्स को बता रहा हूँ। माँ बाप दोनों मतलब टीबी क्लिनिक में ही काम करते थे। रोते हुए हमने, भाई हम पर कैसे आए तुम? बोले साहब वहीं बताया गया, एक बार डॉक्टर साहब से मिल लो। व्हाट आई एम ट्राइंग टू से विद दिस केस, तो मैंने इसको कहा भाई पहला काम तो ये कहा अगर वो ड्रग इंटॉलरेंस हो रही है, वो बेचारा हाई स्कूल का बोर्ड का इम्तिहान दे रहा था, उसको छोड़ देना पड़ा। तो मैंने कहा पहला काम तो करो, दवाई बंद कर दो। देन लेट अस डिसाइड कि है भी एमडीआर टीबी है कि नहीं है। हमें एक्सरे देखने में तो लगता नहीं, लेकिन अब चूंकि जीन एक्सपर्ट की रिपोर्ट है तो ऐसे हम मना तो नहीं कर सकते। सो व्हाट हैपेंड, एंड आई से दैट हम हिस्ट्री लेना भूल रहे हैं। सालवानी साहब, हम पढ़ाना भी भूल रहे हैं। हिस्ट्री तो बात ही नहीं करता कोई, सीधा सीटी और एक्सरे पे आता है। तो मैंने इसका जब डिटेल हिस्ट्री लिया, देखा तो हमें कोई ऐसे सिम्टम नहीं लग रहे हैं, एक्सेप्ट ही हैड माइल्ड epistaxis and mild streaks of blood. Then we went into detail and ATT was stopped and then AFB was negative. Even whole genome sequencing, what Madam has said, we got it done in this patient. No microbacterial growth in whole genome sequencing. This is the report of whole genome sequencing. And even WHO says, देखिए हम एक रिपोर्ट को लेके उड़ते हैं। सबसे बड़ी परेशानी है कि वो सेज अगर भाई आपका वो जीन एक्सपर्ट अगर डिटेक्टेड लो है या वेरी लो है, you have to repeat the test. You have to do some other test before you go to the MDR TB treatment. But unfortunately what is happening, ये हो नहीं रहा है। Anyhow, अब देखिए कहाँ है, एक्सरे में कहीं टीबी है? एक्सरे नहीं, मैंने सीटी भी कराया उसका। देखो ट्रीटमेंट बंद करना है तो बड़ी हिम्मत चाहिए और ऑल एविडेंस चाहिए, ऐसे तो नहीं बंद कर सकते आप। सो anyhow, CT got done, no lesion at all. ETT was discontinued, and still I think I saw this young boy about few days back and a checkup. He is perfectly well. He is very happy कि सर आपने मुझे बचा लिया. So what I am trying to say, मैं ये करता हूँ, अच्छा मैं अक्सर इसमें है नहीं स्लाइड कि भाई देखो मैं 40 साल मैंने MBBS में पढ़े हूँ केजी से, तो शायद हमारे लेक्चर याद कर रहे होंगे कि भाई कोई भी इन्वेस्टिगेशन से डिक्टेट मत हो, टेक देम एज फ्रेंड एंड एडवाइजर। ये हमेशा मैं कहता हूँ, एंड आई फॉलोड दैट प्रैक्टिस इन दिस पेशेंट कि भाई हमें तो नहीं लगता है, एंड ही वाज। सो व्हाट आई एम ट्राइंग टू से, always say, don't treat the investigation. Treat patient as a whole. देखो क्या हो रहा उसमें. Then probably will be followed. I think with this, I'll skip many. We have many YouTubes. अब तो मेरे बहुत YouTube followers हैं. Thank you very much once again, Dr. Ved, for giving me this opportunity to share some of the thoughts about the drug resistant. Thank you very much. I'm sorry,
एक सेमिनार में हम लोग बैठे थे, फ्यूचर में आईएनएस सेंसिटिव हो जाता है 29% केसेस.
I think you are very right. On those days, INH reversal, and especially INH reversal was known in those situations we have no molecular diagnostics. जो मैडम बैठी हुई हैं, जो लो लेवल का जो उसमें भी लोग कहते हैं INH यूज करते हो. Probably that phenomenon. And even हमें अच्छी तरह याद है कि जब उन्होंने आलोकनाथ सामने सन 73 में पढ़ाया रेजिस्टेंस, उस वक्त एमडीआर का नाम, आज भी वो सब what was his depth. Now I have the whole of the world, but I have never seen such a fantastic teacher and mentor. हाँ, राजीव गर्ग भैया और दूसरा. हाँ, अब तो now we know.
Say you can find change at the start of the treatment as well as
मैं तो पहले दिखाता था यार, एक मरीज के 4 कल्चर सेंसिटिविटी रिपोर्ट. अमिता जैन हमसे खफा भी होती थी. चलिए you can do anything. You can as a clinician कि क्या हमें लगता है सही. हाँ.
आप लोग
रिजर्व ड्रग में तो एक्चुअली राजीव गर्ग तुमने एक मैं WHO के टीम के संग आई वाज द वन हु
ये सर हम लोग अकाउंटेबिलिटी सर अब है हमारे देश. आपका खुद का एक्सपीरियंस है और उसके ठीक किए हुए
आज भी ठीक है, आज भी ठीक है. टॉक्सिसिटी हो रही है.
फ्रेंड, मैं एक सवाल सर आपसे पूछूंगा जो पढ़ाते रहे हैं आप.
सब राजीव गर्ग, what is happening all say very clearly. अरे बता this new guideline who remain vocal for 1 hour.
आज के समय आप का ट्रायल करना चाहेंगे, it's not possible. And I am associated with one set of that trial. I am because of accountability. Any new trial?
That's very right. That's very right. But anyhow, that's what is happening.
It's like a cancer. You are given full liberty. ठीक है, so TB is 100% stable drug है, लेकिन ट्रायल करना चाहता है, जितने भी इंस्टीट्यूट ऑफ एमिनेंस हैं या मेडिकल कॉलेजेस हैं या सेंटर ऑफ एक्सीलेंस सो कॉल्ड बना तो रही है, आईयू एक्सीलेंस है, तो आप अपना कोई ट्रायल ही नहीं कर सकते।
I totally.
आप बंधे हुए हैं, आपसे पूछा ही जाएगा, फिर हमारी एथिकल कमेटी पूछ लेगी, साहब ये रिकमेंडेड है, ये आपके में क्या
कहानी सुनाता हूँ राजीव गर्ग, नहीं सुन लो। We did an era, one of, you are also part of that. And in chest X-ray of tuberculosis. मेरा also member of ethical committee. मेरा ethical committee की क्या जरूरत है? डॉक्टर साहब लोग बैठे हुए हैं। देखिए आर्टिफिशियल इंटेलिजेंस कितना छाया हुआ है चारों तरफ। मेरा कहने का मतलब तुम सवाल उठा रहे हो बहुत हाँ नहीं कर आए पर्टिकुलर सेटअप हो रहा है। इंडिया सबको गाइड करता गाइड कर रहे हैं। सिंगल ट्रंकेट स्टडी की बात करी, वो कहाँ सिंगापुर में हुई है। छोटे मोटे कंट्रीज वाले कर रहे हैं, दे आर सपोर्टिंग इट एनी हाउ। There are so many issues.
Thank you, Rajesh.
हाँ हाँ no ऑलरेडी अभी मैं कल से डॉक्टर वेद ड्रग सेंसिटिव पे बोले now the trials are very clear. सेंसिटिव मैंने कहा ना 2 महीने का भी स्टडी आ चुकी है, अब स्लोली एंड स्लोली वो आएगा करने को, बट दिस इज व्हाट वी आर मूविंग टुवर्ड्स। हाँ, तो गाइडलाइन ही ये सब देखो, वो जब स्टडीज तो काफी अच्छे एटमॉस्फेयर में किए जाते हैं, मैं नहीं to change these guidelines and ultimately we are moving towards that.
Sir,
there's no doubt about it. Yes.
एक बेसिक सवाल चाहता हूँ कि जो के इलाज की वो ये था कि हम इस दवा इलाज देते हैं ताकि जो डॉर्मेंट वैसिलाई हैं उनको हम एड्रेस कर सकें। यही आपने पढ़ाया, यही हम लोग पढ़ते हैं। लेकिन जो अब हम देख रहे हैं कि शॉर्ट ड्यूरेशन की जो रेजिमेन आ रही हैं, क्या नया बेसिस है? हम एमडीआर को भी, एक्सडीआर को भी नई ड्रग्स के आने से एड्रेस कर सकते हैं। तो बेसिक जो प्रिंसिपल है ट्यूबरकुल बैसिलस के का, क्या उसमें कोई चेंज आया है या उसके कुछ और जिसको हम नहीं समझ पा रहे हैं?
Raised a very important question. जो करेक्टर है वो नहीं बदला, it remained the same. What has changed is drugs have changed. Now these newer drugs are important. They can
इंटरमिटेंट ग्रोवर्स जो थे,
हाँ, वो सब इन नए ड्रग्स में
4 महीने वो सोए के बाद जग रहे हैं।
नहीं, ये नए ड्रग्स में जो आए हैं, ये बीडाकुलिन, डिलामिनेट, प्रिट्रोमैनेट, ये सब एड्रेस कर रहे हैं इसको, क्योंकि दे आर वेरी पोटेंट ड्रग, दे कैन बी यूज फॉर अ वेरी शॉर्ट ड्यूरेशन एंड दे कैन किल ऑल सॉर्ट ऑफ बैक्टीरिया, डॉर्मेंट, एक्टिवली ग्रोइंग। जैसे वो रिफेम्पिसिन जब आई थी तो उसमें कहा जाता था भाई इस तरह में, इस एटमॉस्फेयर में, इसमें वो सब
ट्यूबरकुलर बैसिलस का एक जब उस पर वर्क करती है एटीटी, जब वो इन्फेक्शन हो रहा है, वो पढ़ा है, ये बताया जाता रहा, डॉक्टर भी हमें
पढ़ा है, ऐसी दवाएं नहीं,
लेकिन जब बाइनरी फिशन करेगा तभी उस पर वो दवा कारगर होगी जो अभी की दवाएं।
अब वो दवाएं आ गई हैं, सब वो नई दवाएं।
तो या तो हम ये कहें कि ये जो नई दवाएं आई हैं, ये जब वो बाइनरी फिशन नहीं करता है बैक्टीरिया, तब भी ये उस पर इफेक्टिव होती है।
भाई तभी तो असरदार हो रही है, नहीं तो क्यों असरदार होती है?
वही हम जानना चाहते हैं।
तो नाउ वी हैव गॉट बेटर ड्रग्स।
This has been demonstrated in both animal models, in vitro and in vivo. Both models, these newer drugs have been compared with the older drugs which were available for treatment of tuberculosis, and the activity. Just a minute, listen, sir, please. Resistance will develop. Resistance is natural phenomena, sir. Resistance will develop.
ठीक है, थैंक यू डॉक्टर।
And the way we are using it, it is likely to more develop. So that is
Thank you.
So, but we have to strengthen the contact tracing.
Sorry, sir, we declare the session closed. If any of the our eminent audience have questions, we can take it at the end of the session.
Dr. Rajendra Prasad, sir. Dr. Rajendra Prasad, sir. I would request sir to please felicitate the persons for this session. Dr. T.P. Singh, sir. Dr. T.P. Singh, sir. Dr. Ashok Yadav, sir. Dr. Raj Kumar, sir. And Kiral Verma, ma'am. Gupta, is Director Sanjeevani Hospital and Research Center. Respiratory Medicine KGMU and Dr. Medicine.
Asking so this is on preventive therapy in tuberculosis. Now, as we know, this the burden of the tuberculosis is highest in the for the preventive therapy. Use the preventive therapy like the household contacts, the patient, other group. Basically, in household contacts, we give treatment to some less than 5 years of age, and then we give the preventive therapy on those patients after getting the IGRA and TS done. So, Alok, he's a professor and head of the Department of Pulmonary Medicine, Sanjay Gandhi Postgraduate Institute, who will tell about what are the limitations, what are the shortcomings, advantage, disadvantage of giving the preventive therapy in our scenario. So, request Rajnish.
Sir is DM in Pulmonary Medicine from PGI Chandigarh, FCCP, Professor and Head Department of Pulmonary Medicine, SGPGI Lucknow. He is expert member for Indian Guidelines for Bronchoscopy. His areas of interest are interventional pulmonology and ILD, and his over 70 publications, over 300 citations to his name. So over to you, sir.
Indian science and concerns about is in the way it has been, or the the way it has been implemented, and making it bacterial infection is a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens with no evidence of clinical manifestations of active disease. The risk of active disease after infection depends on various factors. However, the most important factor is the nutrition status of the patient and his immune condition. These statistics have been talked about, must have been talked about several times in various talks today. India tops the list, that is, India is the TB capital of the world with the 28% share of the global total of global TB burden of the world. And it accounts for 36% of global TB related deaths among HIV negative patients. The current incidence is more than 300 per 1 lakh population. In the last global report, it was told somewhere around 200, but actually the recent data has clarified that the prevalence is much higher than what is being projected, and this is what is actually quoted, but probably it is much higher than this also. And I would like to tell you that prevalence of tubercular infection or tubercular disease, TB disease in Uttar Pradesh is 471 per lakh population. That is around 4,700 per million cases. And we were discussing about development of drug resistance. The first NDRS revealed that there is high level of resistance to any drugs, and also which is both amongst the previously treated and new cases also. TB incidence rate has risen by 3.6% between 2020 and 2021, reversing the all the good work or progress which have been made in last several years. And globally, the estimated number of deaths from TB increased from 2019 to 2021. That is 1 people died from TB, including 1,87,000 people with HIV. And India, unfortunately, was the worst affected amongst these. The highest, India has the highest estimated TB prevalence. We have all, and consequently, India has the highest latent TB infection also, which is around 350 to 400 million patients across the world, I mean from India. We are far behind the goals to the TB and TB strategy, as you can see in this table, that currently we are somewhere around 20% or 35% or 20% for the key indicators of the National Tuberculosis Elimination Program, and we have to go to 90% and 80% till 2030. So much work has to be done, and that has possibly stimulated the government and service providers and all the researchers to probably add much more into it. How can we actually achieve these goals? And this was the probable reason that some brainstorming was done, and it was estimated that if we actually want to control or get our targets, probably we'll have to target the latent tubercular bacterial infection also. This was fueled from the data from mostly from the West, and both from high burden and low burden countries with the help of some studies and trials which were conducted in past. I'm thankful to Darshan for providing me some slides which I've borrowed from him. So these are the model of TB epidemiology that with the risk factor and exposure, how the TB infection progresses from TB infection to disease to death. And the four major pillars of national TB elimination programs are prevent new infection, prevent them to into breaking down into active disease, prevent the emergence of drug resistance, and prevent mortality. Detect all cases, including the drug resistant cases, notify all cases, provide them quality assured treatment, and build case finding systems, active case finding, and reaching out to the majority and depth of the population, and making a very large network of laboratories across the country so as to attain the highest diagnosis. Now the question arises, why do we need to treat LTBI? Everybody knows that about 5 to 10% of patients with LTBI will progress into tuberculosis every year. And looking at the burden of LTBI in India, which is, I just quoted, it is around 350 to 400 in cases. Managing LTBI infection actually can lead to the control, that is the decline in TB incidence from 2.5% per year to 10% per year. This is the basic dogma or basic thought behind treatment of LTBI. I mean, there are too many risk factors for development of or degeneration of LTBI into active TB disease, amongst which is, as I told you, that immune condition of a patient has got the central role to play, along with the nutrition status. Along with that, these conditions listed like HIV, biological treatments, immunosuppressive therapy, tobacco abuse, systemic conditions like diabetes, CKD, and some occupational diseases like silicosis, malnourishment, and surgical procedures like gastrectomy. All these conditions increase the risk of developing tuberculosis, and in large molecular studies which were done way back in a lot of years back, they all were of the opinion that reactivation is the major form of tuberculosis as compared to reinfection. So how do we test for LTBI? Currently, MAN2 test, that is the tuberculin skin test, and the interferon gamma release assays are the most commonly employed test for testing LTBI. Both of them measure type 4 delayed hypersensitivity to mycobacterial protein antigens. TST is an in vivo test, and IGRA is an in vitro test. There is no strong evidence of superiority of one over the other. The choice of the test will depend on cost, availability, resources, and infrastructure for doing that test. TST does not require any specific infrastructure. We all know 0.1 ml of PPD, 2 units recommended by the Indian Academy of Pediatrics, but because of lack of standardization of the tuberculin which is procured, now it is commercially prepared. Tuberculin factory at Guindy was dismantled, so a lot of tuberculin is imported, and there is lack of standardization studies of this kind of tuberculin which is commercially available in majority of the labs at present. So people use 5 tuberculin units also. And we all know the details of MAN2, that it is read after 48 to 72 hours. The criteria for taking it as positive and negative is well described between among various population, and it has got this is a busy slide which lists you how do you interpret a MAN2 test. These in vitro tests, these are newer tests, which is IGRA or the T-spot test. They detect sensitization of M. tuberculosis by measuring interferon gamma release in response to antigens representing Mycobacterium tuberculosis. They have got more specificity as compared to the TST because they represent specific mycobacterium tuberculosis proteins, which are ESAT6, CFP10, and TB7.7. The result can be interpreted as positive, negative, indeterminate, or borderline. If we compare both the tests, actually none of them is superior among each other, but the sensitivity of tuberculosis skin test, specificity of TST is low in already BCG vaccinated individuals. However, for IGRA, it does not have any relation to BCG vaccination. MAN2 or TST is a very low-cost test, and IGRA is a costly test. And the ease of use or the ease of administration of a test can be interpreted with caution, because TST requires 2 visits at least for interpretation of test, and if there is a problem in ensuring the return of the patient after the test, IGRA might perform superiorly to assess the burden of TB infection in a given society or community. So now coming to what is TB preventive therapy, it is a course of one or more anti-tubercular drugs given in with intention of preventing the development of tubercular disease from a patient who is having a latent tubercular bacterial infection. So it is considered, it is being considered as one of the most critical public health measures to protect both individuals and community from TB. According to Indian guidelines, the target population is all patients who are living with HIV/AIDS, adults and children more than 12 months, infants less than 12 months with HIV in contact with active patients, active TB, and household contacts of in amongst the non-HIV less than 5 years of age. These are the standard class 1 indications of TPT. However, the expanded indication is more than 5 years after exclusion of active disease. So the critical point is you have to exclude active disease before you embark upon giving TPT to anybody. Target population, which will be, I think, implemented in the phased manner, will be all patients who are on immunosuppressive therapy, patients with silicosis, on anti-TNF therapy especially, and patients with CKD who are on maintenance hemodialysis, or those who are preparing for solid organ or a hematopoietic stem cell transplantation. This is the basic algorithm which encompasses all the variety of patients. However, currently the Indian program or the Indian scenario is focusing on the household contacts, and amongst that, if the patient has to be assessed before considering them for TPT. If the patient is symptomatic, the patient should be assessed or evaluated with a chest X-ray, sputum examination for active disease. If the patient does not have active disease, patient should less than 5 years, he should be given TPT. And if a person more than 5 years of age, he should be subjected to LTBI testing. If patient is negative for testing, he is not a candidate for TPT. And if the patient is positive, he is a candidate for TPT. The shortcomings or the discussion of all these things I'll take up in the later slides. So the contraindication of TPT are active TB disease, acute or chronic hepatitis, concurrent use of other hepatotoxic drugs, regular and heavy alcohol consumption, signs and symptoms of peripheral neuropathy like persistent tingling, numbness and burning sensation in the limbs, and allergy or known hypersensitivity to any of the drugs which are being considered to be given in the TPT. The pre-treatment assessment should be done before administering TPT. That is, one should be eliciting all the information relevant for TPT initiation and continuation, such as allergy or hypersensitivity to the drugs, HIV status, and the kind of ART regimen he is on, pregnancy status of patient pregnancy status, comorbidities such as malnourishment, diabetes, chronic, and record of all the medications the patient is being given. These are the regimens for which have been enlisted for TB preventive therapy. That is 6 or 9 months of INH daily, 3 months of rifampicin and this INH weekly, and 3 months of rifampicin and INH daily, and 1 month of daily rifampicin and isoniazid. So this is for the drug-sensitive TB. Amongst this, the most evaluated regimes are the 6H and 3HP. And amongst the contacts of DRTB, the literature is still evolving. However, the proposed regimen or the proposed regime is single drug prophylaxis by levofloxacin in patients who are MDR. And if the patients are monoresistant to H or and resistant to and sensitive to R, then rifampicin prophylaxis can be offered to them for 4 months. These are the dosages of 6H regimen. These are the dosages of 3HP regimen. And these are the comparison of the TPD options which are available at present with us, ranging from the duration of treatment, the pill burden, which whether it can be used in pregnancy or not. So 6H is safe for use in pregnancy, but 3HP there is lack of data. Interaction with antiretroviral drugs, 6H there is no restriction. However, in 3HP regimen, the protease inhibitors, nevirapine, and non-nucleotide reverse transcriptase inhibitors are contraindicators, and also tenofovir. But one of the congener of tenofovir, that is disoproxil, is allowed with modified doses, and dolutegravir and raltegravir. These are the other two drugs which can be used with dose modification. Toxicity is present with both, but flu-like syndrome and hypersensitivity reactions were more reported along with the HP regimen. 6H best absorbed with an empty stomach, up to 50% reduction in the peak constriction with a fatty meal. However, oral rifampicin bioavailability is best with if given with meal, and it increases if given with meal. So now coming to what is the evidence or what is the data behind effectivity of these regimes. So from studies from India, in a cohort study from Pune and NIIT Trivallur, among 461 household contacts, the TB infection prevalence was detected with 72%. And another study, C-TRIUMPH study, the LTBI prevalence among the household contacts was 47% as less than 6 years, 53% in the patient with 6 to 14 years of age, and 78% in 15 to 45 years of age. And in a cohort study among 100,600 patients, household contacts in Delhi showed that TB disease was 10 to 60 times more likely in contacts than in general population. Secondary tuberculosis cases in household will develop within first 4 months of the active disease in the index patient. So this forms the basis that why LTBI may be actually an important adjunct for achievement of goals of National Tuberculosis Elimination Program. Outside the index household, the efficacy in patients who are on anti-rheumatic drugs or biological therapy have also been demonstrated. Chemoprophylaxis trials in India have shown that in a study from Bangalore among 992 households with 5,400 population showed direct administration of pills to each participant every day for 6 months by a locally employed person, resulting in a much higher consumption of pills. A weekly regimen of rifampicin plus INH had higher completion rate and less liver toxicity. In a clinical trial, tuberculosis developed in 0.19% subjects in combination therapy group and in 0.43% in isoniazid group, difference of 0.24% points. Compared with 9H regimen, the 3HP regimens had a higher completion rate with lower hepatotoxicity and well-tolerated adverse drug reactions. So, most of the evidence, unfortunately, for LTBI treatment comes from the Western population. All these studies which I have listed in last several years, there was similar preventive efficacy with shorter rifampicin-based TPD regimen, both in HIV positive and negative individuals, as a monotherapy or in combination with isoniazid. The 3HP regimen was also associated with higher completion rate in all subgroups. Two other RCTs which involved adults from with HIV from South Africa, Peru and number of countries with TB incidence of less than 100 per 1 lakh population. These are low prevalence countries. No significant difference was found in incidence of active TB between participants given 3 HP or 6H or 9H regimen. The risk of hepatotoxicity was similar with 3 HP and regimen and in non-HIV patients also. So overall, the efficacy or tolerance of 3 HP regimen has been listed to be slightly better than, or the completion rates have been listed to be slightly better in 3 HP regimens as compared, I mean shorter regimens as compared to the 6 months regimens with the, or 9 month regimen with isoniazid. There is some evidence with in favor of isoniazid monotherapy for TPT also. In a systematic review of randomized controlled trials involving people living with HIV/AIDS in 2009, showed that isoniazid preventive therapy reduces overall risk of TB by 33%, and preventive efficacy reached 64% for people with positive tuberculin skin test. This review also demonstrated that the efficacy of 6-month regimen was not significantly different from a 12-month regime. Another recent systematic review of RCT showed significantly greater reduction in TB incidence among participants given 6-month regime than those given placebo. So as compared to placebo, 6H regimen was better, and systematic review said that efficacy of 6H regimen is also fairly good. So now we come to the unanswered questions. I think everybody is now clear that TPT can be offered with several regimes, the clear indications where TPT has to be used, why TPT is being proposed by the Government of India or by the healthcare researchers, that if we have to achieve our goal, whatever we are doing at present is not enough. Probably we need to do something more to achieve the targets of the National Strategic Plan 2020 to 2025 and achieve the sustainable developmental goals. So now the problems with the current form of implementation of TPT comes. We have some unanswered questions. First of that is the hypothesis itself is confusing. Are we going talking about household contact management, or are we talking about LTBI management? We all know that prevalence is 40 to 50%. LTBI prevalence is 40 to 50%. And if we make a rough estimate in India or in UP itself, the target will be somewhere around 12 crore patients. Around 10 to 12 crore patients who will be target for treatment of LTBI. So role of LTBI testing in management of HHC in the household contact is not clear in the algorithm. They say that household contact, if positive, will be given treatment, and if negative, will not be given treatment. By which I cannot explain with any scientific logic, because according to whatever understanding we have, any person who is TST negative is more vulnerable to develop tuberculosis if comes in contact with a microbiologically confirmed case of tuberculosis than with a TST positive. So doing LTBI testing in management of household contacts is not warranted, I guess, because less than 5 years, we all know everybody has to take treatment. And if you are promoting household contact treatment, then I think you should offer it to everybody in the house, whosoever is coming in contact with the patient. Target population, as I told you, is very high. So if we roll out the program in a larger way, probably it will be having a very high financial burden and may not turn out to be cost effective. The other problem is that community transmission in India is very high. If a person is exposed to tubercular bacilli by an active TB disease member in the family, he is also exposed to TB infection in his day-to-day life also. Our environment has a very high load of Mycobacterium tuberculosis, and the biggest source of tuberculosis for us in India. Constant exposure to the population and development of TB disease may occur in high community because of high community transmission. And recurrent courses of chemoprophylaxis probably might be needed if we actually want to ensure that a person who has LTBI or who becomes converter again in his due course of life, and he becomes TST positive or maybe IGRA positive again in his life, probably he will require another course of TPT. If actually we want to target LTBI in a high burden setting. And we all know that the chances of developing active TB disease in patients with in people with LTBI is 5 to 10% only. So the hypothesis that if we target and treat those LTBI patients, which are a large number of patients, we will have a material difference in management goals. I think this needs reconsideration. I think it needs redeliberation. The other thing that treating LTBI would, as I told you, would be not cost effective. It may just add to the financial burden. And the reservoir of LTBI is therefore a major barrier to the ultimate control and elimination of tuberculosis, but we are far away from our primary goals. As I told you, as I showed you in previous slide, that we are so far behind the primary goals of active TB treatment that bringing in TPT or LTBI treatment probably comes once we have achieved a significant control over the active disease. Then it's worthwhile to target LTBI also, and then probably definitely it can be a game changer, as in West, where the prevalence is 0.5%. The LTBI prevalence is 0.5%. They have already managed their active tuberculosis much more effectively, and now they are mopping up. And probably now, then that hypothesis that we'll bring down the prevalence by 90% by treating LTBI in a given population will hold true. Now, how durable is the protection? There is some study, there are some, literature from Brazil and another study in which they said that it is sustained. It shows sustained benefit up to 6 or 7 years in different population. And from Ethiopia, reduced incidence by 96.3% was shown, and it offered sustained protection against occurrence of TB for 3 years among people living with HIV/AIDS. So these are some study which have been done in West, but probably, unfortunately, we do not have any evidence or data from Indian subcontinent where the prevalence is so high. And we do not have any good quality data in setting like India, where community transmission is high, and a person has high chance of gathering infection after completion of TPT in his later life from the community. May require repeated course of TPT, as just told in previous slide also. So durability in our setting is questionable. Now there are some issues with implementation also. It is extremely difficult in a country like India with such a large target population. We do not have a good quality data from field sitting that whether the current strategy of TPT versus no TPT has come out in the field in numbers also, and in black and white. We have a lot of assumptions based on data which have been actually made available from the West. Compliance and adherence is going to be a major challenge in India. Making a person understand the importance of 6 months of treatment to a patient is a difficult job. A person who doesn't have any symptoms, I think convincing him to take 6 months of therapy or 3 months of therapy without any symptoms is going to be a challenge for people who are healthcare providers who are going to counsel the family for this kind of therapy. And why LTBI negative household contacts are not candidates for TPT, as I briefly mentioned earlier also, it beyond my scientific understanding. Doing chest X-ray and sputum only and symptomatological evaluation may be insufficient for ruling of active disease, and we can land up with trouble. And the way, at present, the way it has been implemented, as far as our knowledge is concerned, LTBI testing is not being done in any center in India except for Barabanki, where probably IGRA testing is being done, as was told to me by in one workshop, in the JEET workshop. Now I'll bring your attention to some other interesting data, that a meta-analysis of 70 cohorts in nearly 750,000 children and adults with TB infection predominantly with high-income countries, only 18% of those who completed the isoniazid preventive therapy versus 49% for rifampicin-based short course regimen. This I'm talking about high-income countries where educational status and other things are good, so it is meager for completion of TPT. Another systematic review of child contact management in high TB burden countries showed that TPT completion varied from 0 to 95%, and more than half of the studies in this systematic review reported less than 50% of completion rate of tubercular preventive therapy. And it has been quoted in the Global India TB report itself that little is known about TPT completion among adolescents and adult household contacts in low and medium income countries. So while short course benefit offers an opportunity for improved TPT completion, much work needs to be done before to be performed to improve our health system, provide healthcare system, healthcare provider, and patient level barriers to achieve high levels of TPT completion rates. TPT has been, documented to be reasonably safe in whatever data we have from this, but there are concerns about development of resistance, which is talked about in all the debates and discussions. Although some data is available which say some modeling studies and cluster studies have showed that it does not promote too much to resistance. But again, this assumption is based on low quality evidence from Western population, which have been extrapolated to our population. The prolonged duration of single drug INH decreases patient compliance and possibility of significant adverse effect, including hepatitis. Evidence suggests that 6 minutes of INH prophylactic LTBI treatment increases the risk of reactivation, tuberculosis, and reinfection. This I came across in a study published in 2000 in AGR CCM. This is a debatable and issue, although it has been documented. Isoniazid is sometimes ineffective against persisters as far as the basic teaching is considered, so it may not be a very good drug for chemoprophylaxis. So before beginning LTBI therapy, those at risk of TB disease should go a detailed clinical examination, and ruling out clinical disease, active disease, is of utmost importance, and shorter and combination therapy probably will be more appropriate and should be encouraged. TPT and drug resistance, the conclusions which has been drawn are based on a very flimsy level of evidence. Well-designed larger trials are needed to assess the chances of development of resistance. In advertent long-term administration of first-line drugs, either single or in combination, and if the patient turns out to be having active disease, can result in catastrophic results. In a study of household contacts from Bengal, including more than 7 lakh patients, the overall secondary attack rate in household contacts was 4.15, which is very high. So with this data, I'm just highlighting that 4 out of 10 people already develop disease amongst the patients, amongst a family with a sputum positive person. And again, although data is evolving, but single drug prophylaxis, levofloxacin prophylaxis of 6 months MDR may be inadequate, and definitely has strong potential to promote drug resistance to a already misused drug for upper respiratory tract infections, UTIs, and so on and so forth. Already it is misused, and the prevalence of resistance is so high. And similarly, in MDR also, in drug-resistant cases also, compliance again will be a major issue. If we want somebody to take levofloxacin for 6 months without any symptoms, because the data which we have shown in many of them, actually the TPT has been observed in DOTS form, but at present, what our strategy is self-administered. So the reliability and the adherence to the regimen, the compliance to the regimen is going to be a problem. Patient might not take it, stop in between or choose like that. So now coming to the last slide, the conclusions or take-home messages. Ruling out active TB before starting TPT is critical and challenging. Counseling of contacts for acceptance of TPT will be a challenge with the full rollout of LTBI treatment. Compliance and adherence and tolerability in current form of TB preventive therapy is a major problem. Its efficacy in high burden countries like India is a debatable issue. More data is needed with good quality evidence base from high burden countries. Targeting only household contacts of confirmed patients only does not solve the purpose, because possibly that is the tip of the iceberg only, and that will lead to futility of the program. And TPT with inadequate drugs has got a very high potential for promotion of drug resistance. Thank you. Thank you for your patient listening.
So thank you, Alok, for the wonderful lecture. As we know that this is going to be, very hard task for the implementation. As you told us, this COVID mein hum log, we were giving the preventive drugs to each and every contact. Here we are saying, no, you go for this, only sub patients, you give this. So this is definitely a shortcoming of the
probably the message is that LTBI treatment has got a potential to be a game changer in a population, and it can really bring down the prevalence and incidence both of a given, in a given community of population. But the major problem is that the active tuberculosis burden is too high. The reported case burden is 28 lakhs, which everybody knows what is the quantum of missing cases in India. So we have lakhs of patient, which actually this figure may be 40 lakhs, 41 lakhs. Which is because of lack of adequate notifications. So before embarking upon LTBI in a phased manner, I read an editorial in some journal, Indian journal only, that we can take example from Vietnam, that they have proposed or they have rolled out in high-risk population first. All CKD, all people with immunocompromised state, silicosis, and all the major risk factors who have got very high prevalence or 10 times the chance of normal population to as compared to develop active TB disease by reactivation. If we give a blanket TB2 to everybody in that only, and then phase it to the household contacts or the overall LTBI population, if our economy allows to do that, and we have adequate infrastructure and manpower to go from door to door for administration of LTBI, then probably we will be in a position to eliminate tuberculosis by 2030. But if we fail in doing this, it can backfire.
Of course. So because we have a very large population in our country,
yes, the major problem
and the counseling of the patients for what you have talking about. टीबी की दवाई तो कायदे से लेते नहीं,
exactly.
तो उनको वो लेटेंट ट्यूबरक्लोसिस के लिए क्या समझते हैं, भैया लें कि ना लें. I'm not sure, and that financial burden is another point.
Yes, the country
so
will
it will be difficult for us to
yes.
implement this program in a good manner.
Targeting 50 crore population of India, 40 crore population of India for treatment of LTBI is going to be a huge financial burden on the country.
I think till 2025 TB elimination is not possible, but it might give some hope. We can eliminate TB till 2020.
And some major steps have to be taken. This is one of the toughest steps which the government has taken. It's our duty to analyze critically or appraise clinically any kind of strategy which is suggested by the by policy makers. It's our duty to do that. But at the same time, I would say steps are being made or tough decisions are being taken so as to make some difference to the outcome. But at the same time, one should not lose the focus. The focus of management of RNTCP, which was RNTCP, now it is NTEP, that we should not lose. the management strategy and the management potential of the infrastructure or the manpower we have should not get confused between the two, and we should not lose the focus from the active disease. Yes. 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 Exactly. Now we have prevention. Yes, exactly. बिल्कुल सही स्टेप है. बस वही थोड़ा सा मे बी जल्दी भी बोल सकते हैं सर, बोल सकते हैं कि शायद हमारी मतलब जो टीम है वो पूरी तैयार नहीं है, शायद मे बी हमें और ज़्यादा आदमी चाहिए, हमें और लोग चाहिए इसको इफेक्टिवली इम्प्लीमेंट करने के लिए. पॉलिसी में कोई बुराई नहीं है, वेस्ट में यही सब चीज़ों ने डिफरेंस पैदा किया है और ये चीज़ें हमारे यहाँ भी डिफरेंस पैदा कर सकती हैं, लेकिन हमारी पॉपुलेशन इतनी ज़्यादा है कि इतने कम लोग मिलकर के नहीं कर सकते, बहुत सारे लोगों को हाथ लगाना पड़ेगा इसके अंदर. Overburdened. They are overburdened. Yes. Yes.
So as you said very rightly, probably it is little early, but then if you have to do, there is no doubt about it's a role.
Yes, sir.
It has been there that if you want to eliminate or end TB, this is one of the strategy which probably what way, how, and how much it should be done. Because we have seen, I have seen these programs for last 2 years. I'm sorry to say, if it is really implemented, programs are very sound, very scientific.
Very scientific.
Everything. But what I say is, implementation is very poor. And that may be our corrector, maybe our own implementation. 25 नहीं तो 30-35 तक लगे. वो तो एक टारगेट
बस सर मेन अंतर वही है ना, जो कंपैरिजन क्या है किससे है, हाई बर्डन स्मॉल कंट्री और हाई बर्डन बिग कंट्री. हमारा साइज ये है, उनका साइज ये है. थैंक यू सर. थैंक यू
प्रोफेसर आलोकनाथ, बहुत अच्छा आपने प्रेजेंट किया.
थैंक यू सर. थैंक यू.
एक होम मैसेज ये है कि अगर आप इसको नहीं करेंगे तो 2025 और 2030 तक एलिमिनेट करने के लक्ष्य की तरफ बढ़ेंगे. और अगर आपने इसको इम्प्लीमेंट किया तो हिंदुस्तान से ये लक्ष्य जो है कम 50 साल और आगे बढ़ जाएगा.
नहीं
सारी एनर्जी इसमें लग जाएगी.
नहीं ऐसा नहीं है सर. ऐसा नहीं है. इतना पेसिमिस्टिक क्यों हो सर. आशावादी रहना चाहिए. आशावादी रहना चाहिए. नहीं सर, ज़रूरी भी है, आवश्यकता भी है इसकी, ऐसा नहीं है कि इसकी ज़रूरत नहीं है, इसकी ज़रूरत तो है, ज़रूरत है। अगर इसी स्पीड से नहीं चलेंगे तो बहुत पीछे रह जाएंगे।
लोग शायद राजीव गर्ग को शायद याद होगा, कुशवाहा को भी याद होगा, मैंने कीमोप्रोफिलैक्सिस का लेक्चर केजीएमसी में शायद 30-40 साल लिया होगा, 15 मिनट में पढ़ाता था। व्हाट इज
कीमोप्रोफिलैक्सिस
प्राइमरी, याद होगा आपको? और मैं अल्टीमेटली ये कहता था, मैं बात कर रहा हूँ मतलब 1920 की, कि भाई ये इट्स अ गुड प्रपोजिशन, लेकिन अभी हमारा देश इसके लिए
तैयार नहीं है।
तैयार नहीं है। अभी हम इसको नहीं, अभी हम इंडिविजुअल बेसिस पे तो सोच सकते हैं कि जैसे भी आलोक ने कहा भाई हाई रिस्क वाले को भी लेते हैं, मैं तो खैर तो पहले भी इस्तेमाल होती थी, अभी भी
उसमें सर बहुत ही वो है, पिक एंड चूज है, जिसका मन करता है वो देता है, जिसका मन करता है वो नहीं देता है। वी शुड मेक अ पॉलिसी, वी शुड मेक अ पॉलिसी फॉर देम एटलीस्ट। CKD, CLD इनको चाहिए, देना है, सबको देना है। एंटी रोमैटिक ड्रग्स TNF देने जा रहे हैं, उसको प्रोफिलैक्सिस देनी है। इतने सारे कॉम्प्लिकेटेड केसेस देखने को मिलते हैं, बायोलॉजिकल्स देने के बाद डिसेमिनेटेड ट्यूबरकुलोसिस लेकर आ जाते हैं, जस्ट बिकॉज किसी ने असेस नहीं किया इम्यून सिचुएशन, उसका TST करके देखा ही नहीं किसी ने। So TB vaccines actually they are in the pipeline. Probably we have not been able to achieve that amount of success rate in the TB vaccine in phase 1 trial itself. So we are quite far from vaccination. So at present we have to focus all over the globe. TB vaccine have not been found to be effective to the tune which it should be across the globe. Not in India, I mean everywhere. So all the world is, I mean the pharmaceutical companies and researchers are on it. They are on the job to make a effective TB vaccine, but probably we are too far from it. So we have to do something in between. Otherwise, the potential for a I mean nova of tuberculosis is not far away. TB preventive therapy itself is a new kid on the block. So data for its adverse drug reactions are ADRs are there, but paradoxical reaction will happen once somebody has got manifestation, and that manifestation increases. But yes, sir, the definition of paradoxical reaction is increase in the existing manifestations or appearance of new manifestations. But here, patient should not have any manifestation. Patient should be absolutely asymptomatic. Then he is a candidate for TPT. Yeah, he doesn't. That will become. No, sir, it will become fear. Or that was harboring TB disease, and that was missed at the outset itself. So it will not be called paradoxical. It will be called development of TB disease and failure of TBT. Then you have to treat that patient. Thank you, sir.
So thank you, Alok. So we close the session here. Thank you.
I would request Rajen Prasad sir and Ved Prakash sir to please felicitate Dr. Aloknath sir. Chairpersons Dr. S.N. Gupta sir. Dr. Ankit Katiyar, sir. Dr. Rajni Srivastav, sir. I'd request Aloknath Gupta, sir, for a group photograph, please, sir. Thank you. For the next session, I would like to invite chairpersons on stage. Dr. Anand Gupta, sir, Senior Consultant, Pulmonary Medicine, Balrampur Hospital. Dr. Jugendra Singh, sir, he is a Senior Consultant, Pulmonary Medicine, Medanta Hospital. And Dr. Jyoti Bajpai, ma'am, she is Assistant Professor in the Department of Respiratory Medicine, KGMU.
Good evening to all. Thank you for being here in this evening. We are heading towards today's event, tuberculosis update. So I would like to welcome Dr. Ved Prakash, sir. He is the organizer of today's event. Sir is a former MD, Superintendent KGMU Lucknow. He is a Young Achiever Award, got the Young Achiever and Corona Warrior Award. And he is a professor and head of Department Pulmonary Critical Care Medicine. So we are delighted to hear you, sir. Your topic is for today's talk is drug-sensitive tuberculosis. So we have learned about MDR, latent TB infection, now coming to the drug-sensitive TB. What is the newer updates? Thank you, sir.
Thank you, Dr. Jyoti and other chairpersons. And probably I have been pushed. मेरा दूसरा तीसरा टॉक था. बीइंग द जूनियर मोस्ट, तो मुझे पीछे तक खिसका के अभी तक यहाँ तक ला के छोड़ा है. अब सब कुछ लेकिन बातें हो चुकी हैं. मुझे मेरे लिए अच्छा ये है कि ज़्यादातर बातें हो चुकी हैं जो मुझे बतानी थी, जो सेंसिटिव टीबी के लिए. हमारे बस 5 ही मिनट लगेगा. इतना है सर, इससे ज़्यादा नहीं लगेगा, क्योंकि हम लोगों का जो रोल था वो सब लोगों ने कर दिया है. बहुत जल्दी स्किप करूँगा सर. सो आवर ग्रेट टीचर प्रोफेसर राजेंद्र प्रसाद सर इज़ हियर, and the journey of tuberculosis, Department of Tuberculosis, then TB and chest, then pulmonary medicine, then pulmonary and critical care medicine. So he remained the always guiding force for all of us, and he is the teacher of teachers, we can say. And for our department, he is the backbone, I can say, in the development and creation of this department, which is our DM students are here for training, and this was the vision and dream of our mentor, Professor Rajendra Prasad sir. So thank you, sir, for being with us always. I will cover in introduction, definition of various types of TB, diagnosis and overview, then treatment, new regimen, and take-home message. So tuberculosis, this was the statement of then Prime Minister Jawaharlal Nehru, Pandit Jawaharlal Nehru, ki whether we ourselves have escaped from the scourge of tuberculosis or not, there is probably hardly a family which has not had to do something with this dreaded disease. So this was the challenge at that time, and now we all are facing it, and now we have to make it a Jan Andolan for participation of all corners of the Indian population. So tuberculosis known since Vedic era like Kshay Rog or decay. Similar description in Hippocrates also like thesis. And this was the man who changed the thinking and understanding about the dreaded disease. He was German scientist Robert Koch. So 24th March is the day when he discovered Mycobacterium tuberculosis and get the Nobel Prize in 1905. So this is the theme for 2023. Yes, we can end the TB. Then we have to take some, we need to know about the definition of some terminology like presumptive TB, a person with any of the symptom and signs suggestive of TB include cough for 2 weeks, fever for 2 weeks or more, then significant weight loss, hemoptysis, any abnormality in chest radiograph. In addition, contrast or microbiologically confirmed TB patients, especially in immunocompromised patients. Then presumptive extrapulmonary TB, presence of organ-specific symptoms and signs like swelling of lymph node, pain and swelling of joints, neck stiffness, disorientation, and other constitutional symptoms like significant weight loss, persistent fever for 2 weeks or more, night sweats. Then what will be the case? Presumptive TB case from whom a biological specimen is positive for acid-fast bacilli or positive for Mycobacterium tuberculosis or culture or positive for tuberculosis through rapid diagnostic molecular test, then we will label it as a case. Then clinically diagnosed TB is presumptive case who is not microbiologically confirmed but has been diagnosed with active TB by a clinician or on the basis of radiological abnormality, histopathology or other clinical signs. So classification based on the site, that is pulmonary TB, then extrapulmonary TB we have discussed, then miliary TB, and a patient with both pulmonary and extrapulmonary TB should be classified as a case of pulmonary tuberculosis. Risk of infection. Smear positive pulmonary TB case infect 10 to 15 other persons in a year. So it is a real threat, real challenge for us to eliminate pulmonary tuberculosis and remain infectious for 2 to 3 years if left untreated. So risk of developing disease after TB infection, the lifetime risk is 10 to 15%, increased to 10% per year among those with HIV. Other determinants like diabetes, smoking, tobacco, alcohol, malnutrition are the other risk factors. Then TB notification in 2012 it made mandatory and declared the emergency. But you know, we have not followed, so then the ministry came with the gazette notification that made the Ministry of Health and Family Welfare. We have not following the advice, so Government of India came with stringent measures. All clinical establishment, doctors, laboratories, pharmacists, chemists and druggists that fail to notify tuberculosis patient will be booked under section 269 and 270 for of the Indian Penal Code that carries a jail for 6 months and 2 years of a fine or both. So we should comply with the guidelines. So these are the diagnostic tools. I will skip some of slides. This has already been taken up. Then this is universal drug sensitivity testing, refers to universal access of rapid DST for at least rifampicin, and further DST for resistance preferably before initiation of treatment to maximum within 15 days of diagnosis. So all to undergo CBNR testing now. Then current management of drug-sensitive tuberculosis. How it developed, like we were in pre-chemo therapeutic era since 1944. Then basic treatment was nursing care, good nutrition, fresh air, described in Ayurveda also, then sanatorial treatment, then first drug came in 1944. So it was streptomycin, then PAS, isoniazid, thiazidazole, ethambutol, and now we have in 2012. So with a gap of 30 years, we have bedaquiline and delamanid, the new discoveries in the basket. So these are the newer drugs added in the basket. These are the first line drug, then second line drug, and then the newer drugs, bedaquiline, delamanid, and pitomanid. Then goal and objectives of TB treatment for sensitive TB. Render patient non-infectious, break the chain of transmission, this is the goal, and decrease case fatality and morbidity by ensuring relapse, free cure, minimize and prevent development of drug resistance. Then role of intensive phase, that is rapid stop bacteria multiplication, killing every bacteria. Then role of continuation phases to ensure elimination of persisters which are responsible for relapses. So these are the intensive phase for 2 months, then continuation phase for 4 months, and FDCs. These are the advantages of fixed dose combinations. These are products containing 2 or more active ingredients of fixed doses in NTAP for adults. 4 FDCs given in IP consist of HRJD, and then 3 FDCs in continuation phase like HRE. So advantages are simplicity of treatment, then increased patient acceptance, then increased healthcare worker compliance, then easier drug management, reduced use of monotherapy, lower risk of emergence of drug resistance, and easier to adjust doses by body weight. So these are the body weight bands. Newly added this 6 tablet in 75, more than 75 kg, we have to give 6 tablets. Then when to change the weight band? Weight increases or decreases by 5 kg or more, then we will change the weight band accordingly. And what is new? I want to focus on 2 trials. Treatment of drug susceptible tuberculosis. These are the trials. Long treatment regimen presents serious challenges to programmatic management of TB globally. So the focus is to reduce the treatment duration. Shortened treatment has the potential to improve adherence and reduce patient and health system costs. A recent randomized control trial, TBTC1 study 31, ATCG2. This study 31, we can say, assessed the safety and effectiveness of 4-month regimen for the treatment of drug susceptible TB. Key findings of study 31 were, it was randomized multinational open label controlled phase 3 trial comprising 4-month rifampicin containing regimens of the standard 6-month control regimen, and the trial controlled participants who were 12 years older and newly diagnosed pulmonary tuberculosis cases. The primary efficacy outcome was tuberculosis disease-free survival at 12 months after randomization. The efficacy of the 4-month rifampicin-based regimen containing rifampicin, isoniazid, pyrazinamide, and moxifloxacin was non-inferior to the standard 6-month regimen. So the other 4-month regimen composed of rifampicin, isoniazid, ethambutol, and pyrazinamide didn't meet non-inferiority criteria and therefore was not reviewed. So this was the, in CDC conducted this trial, and WHO approved approved this trial. And in February, United States Center of CDC conducted this trial, and intensive phase 8 weeks of high dose rifampicin, isoniazid, pyrazinamide and moxifloxacin administered once daily. In continuation phase, rifampicin, isoniazid and moxifloxacin. The shortened regimen is now an option for certain patients more than 12 years old, patients with HIV. We have to take care. So these are the 4-month regimen for body weight more than 40 kg, less than 40 kg, and age less than 12 years, pregnant or breastfeeding. These are the contraindications for which in extrapulmonary also we have not to give. And another trial, yes, we have to be cautious in prolonged QT intervals syndrome and current use of one or more QT prolonging medications in addition to moxifloxacin. And another trial that sir was talking about, that was the truncate TB trial. It has been conducted in Singapore, supported by Sanofi and Pfizer. And this was the conclusion. They take 3 arms. One is standard regimen, then bedaquiline plus linezolid for 8 weeks plus HZE, and another arm with rifampicin plus linezolid plus HZE. So 3 arms were compared, and among participants with rifampicin, susceptible pulmonary tuberculosis, a strategy involving initial treatment with an 8-week bedaquiline linezolid regimen was non-inferior to standard treatment with respect to clinical outcomes, with no apparent safety concern. So the response was non-inferior. Side effect profile was same, and 8 weeks regimen combining bedaquiline and linezolid with HZE is non-inferior. So this was for 8 weeks. And my last slide, take-home message: universal DST, confirmed TB and resistance at the start of ATT, standard treatment, intensive phase 2-month, continuation phase for 4 months, 4 drug newer regimens like rifampicin, isoniazid, pyrazinamide and moxifloxacin may be game changer in future. So thank you for patient listening.
Thank you, sir, for inviting me. Such a very good presentation. Thank you, sir. And I would like to add something. What I have seen in my practice that we should consider in our country the tuberculosis in the foremost in the differential diagnosis. Until you will not suspect it, you will not search it, and you will not find it, and the treatment will not be there. I have seen the patient, especially the immunocompromised patient, the methotrexate, the lady came with on rheumatoid arthritis on methotrexate, and with short history of 7 to 10 days only with breathlessness and the CT suggestive of frank ARDS fluffy cytos. And the only report, the BAL PCR panel was negative, and only report came out to be positive gene expert. So this lady was on ventilator with septicemic shock. The PCT was very low, and the TLC was also total leukocyte count was also low, and so the only diagnosis made was TB ARDS, and subsequently we managed this patient with the high dose of steroid therapy along with the tuberculosis and not other antibiotics. The antibiotics were discontinued. She came out from the ventilator and recovered from the tuberculosis. And I have also seen the patient like the COPD patient who presented with acute exacerbation with type 2 respiratory failure, and CT suggested the thin bud pattern, and the BAL positive was gene expert positive. So even in the what I am trying to say that we should suspect, and we should search it, and we should find it or rule out it in our country and day-to-day practice in our clinical scenario. So we should think
about this clinical scenario? Can this is because of the tuberculosis as far as the lung infection is concerned? Thank you, sir.
Thank you.
Any question from the House? If there is no questions, then thank you, sir, for enlightening us with the wonderful talk and enlightening us about the new trials, truncate trials. Since morning, I am listening about the truncate trial and newer trials which shown by you. So it is a good thing for future. We are heading towards the NTB program. Might be we have to be optimistic. We can end TB 2025 or might be much longer, but we all have to be so hopeful regarding this. So thank you, sir, for this lecture, and I think the session has been closed. Thank you.
Thank you. Thank you.
Thank you so much, sir. I would request TP Singh, sir, to please come on stage and felicitate Dr. Ved Prakash, sir. I would request TP Singh sir and Ved sir to please felicitate our chairpersons for the session, Dr. Anand Gupta sir. Dr. Joginder Singh sir. And Dr. Jyoti Bajpayee ma'am. All good things must end. So we'll be ending today's update on tuberculosis by vote of thanks by the organizing secretary, Dr. Ved Prakash sir. Request sir to please deliver the vote of thanks. We request first Dr. Sachin sir, co-organizing secretary for Tuberculosis Update 2023 to deliver the vote of thanks. Thank you.
This is really very appreciating event organized by all the organizers, and I really thankful to all of you, Ashok Yadav sir, and sir, for the active for guidance. Always we always hope and help for all the guidance and support which has been teachers. Thank our and the stage team. I would like to thank media personnel. I would like to thank such a beautiful event. Thank you so much.
Thank you, sir. Now I request Ved Prakash sir to kindly give a memento to Dr. Sachin sir.
Like to take this opportunity to felicitate our young and leaded by Dr. Hemant, Dr. Arif, request Professor T. Singh sir and young team, Dr. Hemant. They have Dr. Anurag, Dr. Mrityunjay. He is DM second year. Dr. Anurag working tirelessly for the event. Dr. Anurag is also Deepak first year Dr. Subra is so I would like to thank बैक स्टेज के जो हमारे ऑफिस है यहाँ पे हैं कि नहीं राजन यादव जी राजन को सुनना पड़ता है सबसे ज्यादा उसके ये महामंत्री हमारी जो एसोसिएशन है उसमें कर्मचारी हैं तो परिषद के मंत्री रहें तो इसका फायदा मिल जाता है हम लोग को। ये सब जहां भी काम करता है राजन है वहां से सब करूंगा कि राजन को फेलिसिटेट करें बुकिंग सिस्टर इंचार्ज हैं कि नहीं मर्सी से उनके श्वेता है श्वेता को दे दीजिए टोकन ऑफ और उनकी तरफ से है कोई आप जानिए सिस्टर इंचार्ज की तरफ से चलो हाथ लगा के हाथ लगाओ हाँ सर so now we are coming to the end of this program event and more than 5,000 it was in dual mode more than 5,000 persons has been distributed the ID it has been read on in all the country of my all for the success सभी लोग लास्ट तक हम लोगों की मदद के लिए रुकते हैं तो मैं आपको बहुत बहुत धन्यवाद देता हूं सर हमेशा हमारे लिए एक बैकबोन की तरह एंड पिलर ऑफ आप सबका मैं धन्यवाद देता हूं बहुत धन्यवाद